Welcome back. Let us start the session with seizures in epilepsy. So the first thing, as we have been discussing, is to differentiate between the seizure versus epilepsy. So we know what is seizure. So what is epilepsy? According to the ILA 2018 guidelines, it's something different. So for example, the old definition says that if you have at least 2 unprovoked seizures happening at least 24 hours apart. So this is the old definition, but according to the new definition, ILA 2017, the definition of epilepsy is just having at least 1 seizure plus substantially increased risk of recurrence. So there have been a lot of risk models suggested by ILA in 2017. According to that guidelines, what do you mean by substantial increased risk? Is more than 60% risk, more than 60% chance of having a recurrence in the next 3 to 5 years. In the next 3 to 5 years is what we define as epilepsy. So which means either you can follow the old one or you can follow the new one, doesn't matter. But just for your additional information, you might be needing to know the newer one also, because examiners might be asking this particular newer definition. According to newer definition, just 1 seizure is enough. But with the substantially increased risk of recurrence in the next 3 to 5 years, the increased risk means, according to the models proposed by ILA, it should be more than 60% at least. So this is what we refer to as epilepsy in the first place. So how will you classify seizures? So now we are moving into the core classification of seizures. So how will you classify this? Even before that, so what do you mean by unprovoked? Because we have introduced some term called an unprovoked seizure. So what do you mean by an unprovoked seizure, and what do you mean by a provoked seizure, by the way? And this is also very clear that epilepsy is a part of seizure. It's not a separate entity. So for example, if you take a patient who's having a seizure, so if you take them as a broad spectrum, epilepsy will be a part of that. So when you have more seizures and increased chance of recurrence, those group of patients are the ones who will be called as epilepsy rather than just a seizure. So which means epilepsy is just a part of this seizure disorder. So that's fine. So now our idea is to ask yourself a question. What do you mean by an unprovoked seizure, and what do you mean by a provoked seizure? Unprovoked seizure means you don't have any background risk factors, or there is no clue with regards to the reason for the development of the seizure. So that is what we refer to as unprovoked seizure, which means there should be something called a provoked seizure, which means there should be some background reason for the development of seizure. So what are the risk factors of having a provoked seizure, by the way? What are the risk factors? So because that understanding is important, because you need to know the recurrence rate between unprovoked versus a provoked seizure. Yes, there are many reasons out there. For example, certain drugs can induce seizure, we know that. And fever can induce seizure, especially in children, called as febrile seizures, we know that. And sleep deprivation for a long time can result in the development of seizures. So one has to ask the history of working in the night shifts, and all this stuff are really, really important. And we have metabolic reasons for development of seizures. Of course, many people are commenting. Hypoglycemia, yes, of course, it's a great mimicker. Hypoglycemia, then you can get seizures with hyponatremia, you know that, because they can cause cerebral edema, and because of that they can get seizures. And hypocalcemia can induce seizures as well. And even pyridoxine deficiency has been known to cause seizures in children. In neonates, routinely you give pyridoxine infusions, isn't it? So that could be the reason for the seizures. And apart from that, you have eclampsia. That's a separate entity, we know that. And many acute neurological conditions like stroke, hemorrhage, then trauma, traumatic brain injury, then of course space occupying lesion in the brain, or even conditions like PRES, hypertensive encephalopathy. All these things can cause seizures. Yes, asphyxia during birth can cause seizures, but that's more of a neonatal issue, so we're not going to discuss here right now. So these are some of the entities for getting a provoked seizure. So you need to keep this in background, and you have to ask the history properly. So why the difference between provoked and unprovoked is important? Because as far as the provoked seizure is concerned, because there is a background risk factor, if you remove that risk factor, the risk of recurrence must be extremely less, which means the recurrence rate with that of a provoked seizure is going to be less than 20%. As far as the unprovoked seizures are concerned, the recurrence rate is extremely high. For example, it can be as high as 80%, which means the general risk is around 20 to 80%. I think you're not seeing that properly, so I'll just pull a little bit down. So the recurrence risk as far as unprovoked seizures are concerned is up to 80%. That's why unprovoked seizures are having a more risk of recurrence compared to that of provoked seizures. That's why even the definition of epilepsy says that it is unprovoked seizures with significantly increased risk of recurrence, which means what I'm trying to tell is even any unprovoked seizure is going to have a high risk of recurrence of up to 80%. So that's why that history is really important. So what has provoked the seizure really? So now as we move on to the seizure itself, so seizures can be basically divided into many different types are there, but usual classification what we do is to differentiate between a focal seizure versus a generalized seizure. So this is the basic difference and basic classification of seizures, focal versus generalized. Focal, we can divide further into without impaired consciousness, which means the patient is well conscious and aware, or you can have with impaired consciousness. With impaired consciousness. This is the current classification, even though previously there have been many names that have been given to that. So for example, this focal without impaired consciousness, previously I've been given a name called a simple partial seizure. Everyone knows that. And this focal seizures with impaired consciousness previously were called as complex partial seizures, or seizures that are focal with dyscognitive features. So there have been multiple names for that. Dyscognitive features or dyscognitive symptoms. So this is another name for that. I mean, that's the old name, basically. We don't use that. So currently, the classification of focal seizures means either with impaired consciousness or without impaired consciousness. Without impaired consciousness previously was called as simple partial, and with impaired consciousness previously was called as complex partial or focal seizures with dyscognitive features. And we have a lot of types of generalized seizures as well. For example, the hallmark of any generalized seizure is going to be the GTCS, that is generalized tonic-clonic seizure, one of the very common types of seizures that we see in practice. And apart from that, you can have other generalized seizure types like absence seizures. We know that we have other types like myoclonic seizures. For best example is juvenile myoclonic epilepsy. Sorry for that, I'll rub this. Then we have seizures like tonic seizures, pure tonic, and we have pure clonic type of seizures. And finally, we have this kind of atonic seizures as well. So many different types of generalized seizures are there, but nevertheless, many of the seizure types like absence seizures, juvenile myoclonic epilepsy or myoclonic seizures, they can progress to have a GTCS. Remember, whenever absence seizures comes alone, we are going to call that as typical absence or classical absence seizure. So whenever absence seizure is associated with other seizure types, for example, if it's degenerating into a GDCS, in that setting, we'll be calling it as a atypical absence seizure. Or even myoclonic seizures have a higher risk of developing GTCS. Any of the seizure types can have a risk of development of generalized tonic-clonic seizures. In fact, this simple partial seizures, we call it as focal seizures without impaired consciousness, can become like complex partial seizures, that is focal seizures with impaired consciousness. Or this focal seizures with impaired consciousness can give rise to the development of GTCS over a period of time. So this type of GTCS is what we refer to as something called a secondary GTCS. So they can degenerate to produce a generalized tonic-clonic seizure. So which means there is a considerable overlap, and any patient can degenerate to develop a generalized tonic-clonic seizure. So it's all about the onset. So which means this entire classification, you might ask me what is the role then? So if all the patients can degenerate to GTCS, then what is the idea behind this classification? This classification is based on the seizure onset. So which means at the time of onset, at the onset of the seizure, so what is the type they are encountering, whether it's a focal or it's a generalized. Later on, they might degenerate to GTCS. That's not a problem here. But at the onset, at the beginning, so what is going to be the type of the seizure? So that's what is going to tell whether it's a focal seizure or a generalized seizure. And GTCS, as such, when you go for a generalized seizure, they have some typical manifestations. We know that. But usually in exam, what they really tend to ask is this kind of a focal problem. So what kind of focal problem you encounter? If the seizure originates from frontal lobe, what kind of focal problem you're going to encounter? If it's originating from temporal lobe, what kind of focal problems you're going to encounter? And if it's originating from parietal lobe, what kind of focal problem you're going to encounter? The first one, let us start with the frontal lobe, which actually the seizure originating from the temporal lobe is quite common. I mean, if at all you ask where the seizure originates from, in most of the cases, I will answer it's a temporal lobe. Temporal lobe is a high risk area for origination of seizures. That is why for majority of the seizure surgeries, they remove part of the temporal lobe, like amygdala, hippocampus, and anterior segments of the temporal lobe is the ones that are removed basically. So we'll see that later on. So, but nevertheless, the frontal lobe, origin of partial seizures or focal seizures, will be usually having a kind of a contralateral motor activity. We know that. Contralateral motor activity. So that is what we refer to as something called a clonic jerk. Whenever you have this movement kind of a thing, so that will be called as a clonic jerking. So that's what usually will happen when the seizure is originating from the frontal lobe. Suppose if the seizure is originating from the temporal lobe, and this is very important because they have a variety of picture. For example, one of the common features that these people complain, or these patients complain, is the classic epigastric rising. They have some kind of a rising sensation from the epigastric region. Maybe they might think initially like an acidity or whatever it is. So they'll have some kind of an epigastric rising. So that's a very common sign of temporal epilepsy, and in exams that also becomes a very important question. And apart from that, they can develop that deja vu. We know what do you mean by deja vu? A false sense of familiarity whenever you encounter something. So that is what we refer to as deja vu. The opposite of that is jamais vu. But nevertheless, deja vu is one of the important symptoms of seizures. Then apart from that, we have aphasia, because it's originating from the temporal lobe, and they can have complex auditory, olfactory, at the same time, gustatory sensations. Because all these things, the relays to the temporal lobe only. So of course, they can get auditory, gustatory, or olfactory sensations. But very commonly, what these patients complain is the epigastric rising only. And number 3, you can have parietal lobal seizures. So if the seizures are originating from the parietal lobe, typically we know they are going to have sensory involvement, because somatosensory cortex, the primary sensory cortex, is located in the parietal lobe. So they can develop contralateral pain, numbness, or even paresthesias. So seizures can produce both positive symptoms as well as negative symptoms. It's unlike migraine or TA. Migraine generally produces positive, TA generally produces negative. Seizures can produce both positive symptoms as well as negative symptoms. Numbness or paresthesias, both are possible. And apart from that, if the seizure is going to originate from the occipital lobe, it's quite simple to understand. They're going to produce a sudden kind of a hemianopia, that is contralateral homonymous hemianopia, so which you've been describing for quite a long time. And at the same time, they can have a non-formed, it will be a poorly formed, not well-formed, non-formed hallucinations, which means it will not be completely a formed kind of a movie kind of a thing. They can get glimpses of certain objects that do partially. So that's called non-formed hallucinations. On the other hand, your Lewy body dementia, we have talked about Lewy body dementia sometime back. Yesterday, I think yesterday we talked about the Lewy body dementia, or NCD associated with Lewy body. So in that, we talked about complex formed hallucinations, where it will be like a real movie and kind of a full picture that will be well formed. So that's one of the examples of formed hallucinations that you will get in NCD, neurocognitive disorder with Lewy bodies. But in the setting of seizures that originate from the occipital lobe, you generally tend to get this kind of non-formed hallucinations very commonly compared to the formed hallucinations. Out of all these things, as I told you multiple times, the temporal lobe origin is quite important, and that's what will be asked in majority of the exams as well. So before going into the actual like clinical features or the types of the seizure, so let us start with the anatomy of the seizure. So anatomy of the seizure. As far as the anatomy of the seizure is concerned, so you have the first trigger, that's it happens over hours to days. So we'll have a classic trigger. It might be a simple sleep deprivation as well. So you have initial trigger. Then before the seizure happens, in the seconds to minutes, they tend to have an aura. This is typical. I'm not telling this will be the case in all the seizures. This is very typical. So aura in the form of a focal seizure like epigastric rising or probably contralateral clonic movements. So possible. So they're going to have a focal seizure. This is an aura phase. And next they will have in the first 1 to 2 minutes, which means this is what we refer to as an ictal phase, because this is the time where the actual seizure shows off. That's called as an ictal phase. So where the impairment in the body parts start and the patient starts getting tonic-clonic type of a movement. And apart from that, in few minutes to hours, so remember the seizure usually lasts for less than 10 minutes. It will not be for more than 10 minutes most of the times. If it is for more than 5 to 10 minutes, we generally call it as a status epilepticus. That's a different kind of a scenario. But in general, they don't go for more than 5 to 10 minutes. So it will be usually for 1 to 2 minutes. That's the classic ictal phase. And in the following minutes to hours, they go for something called a post-ictal phase. Everyone would be aware of that. So what do you mean by the post-ictal phase? They're going to produce something called as a disorientation. The patient will be very confused in the post-ictal state. I think everyone would have, encountered this phase where the patient will, will be disoriented. They'll not be responding properly to your commands. They don't know where they are present at that point. So that's very classical in the minutes to hours. And tongue bite is very classical during this phase. Incontinence is also very classical during this phase, the post-ictal phase. And certain musculoskeletal problems also can happen during the post-ictal phase, like, for example, a Todd's palsy. We know that. So Todd's palsy is nothing but a post-ictal weakness of the limbs. Usually it will be on the contralateral side to the site of origin of seizure. That's something quite easily understandable. So we need not tell much about that. So as far as the seizure anatomy is concerned, a classical seizure starts, which means the start of the seizure, you can tell like it's going to start hours to days before in the form of a trigger. Then in the few seconds to minutes before the seizure, they're going to get an aura in the form of a focal seizure. That focal seizure will become a generalized seizure, that is an ictal phase in the form of tonic-clonic movement, and they'll get a lot of there'll be accumulation of the dyscognitive features, and in the ensuing minutes to hours they're going to encounter something called a post-ictal phase, where the classic tongue bite, incontinence, disorientation, and muscle weakness starts. So that's called a Todd's palsy. Not all the seizures will follow the same pattern, but this is how you, at the basic level, typically describe the anatomy of a seizure. So fine. So what are the clinical features of a seizure? So how will you identify clinically that the patient is probably having a seizure? Seizure is classically described with certain keywords. So for example, these are stereotypic movements. So these movements can be lip smacking, like this, vocalization. So some stereotypic movements can be there, and more often it will be rhythmic in nature. And these are very characteristic feature of a seizure. Anything that is not stereotypic and non-rhythmic, we think about more of a functional problem. But nevertheless, you cannot rule out a seizure. It's like a VT only. You can diagnose a VT, or it's you can diagnose a seizure, but it's very difficult to rule out a seizure. So it's like you can remember like a ventricular tachycardia. So it will be stereotypic, it will be rhythmic, it will be very brief. For example, a patient who is having good cognition and has been having the seizure movement for hours together, I will not take it as a seizure. Most often it will be a pseudo seizure, a functional kind of a seizure. But again, like it depends on the context where you're going to classify. But I will think of a seizure only if it happens in a way for a very brief time. So if the seizure is going to happen for hours together, and if the patient is well, and that's not possible basically, because seizure is something that's going to cause severe brain anoxia, severe increase in the cerebral metabolic rate. You can imagine like a kind of an arrhythmia to the heart. If there is an arrhythmia to the heart, you know what's going to happen. The diastolic time will shorten and the blood supply to the heart will reduce, because the shortened diastolic time will reduce coronary blood flow, and you're going to result in ischemia and myocardial infarction. Similarly, as far as seizure is concerned, if it's the more time it's going to happen, the more is going to be the risk of brain hypoxia and brain hypoperfusion, because they suck the blood like anything, because it's a high activity of the brain, and they'll go for global ischemia, and there's a lot of risk of death also, and even they can result in arrhythmias and death, and falls, fractures. So many complications are there with seizure. So a seizure that is happening for hours together with no cognitive disturbances. Patient is just throwing some seizure movement that's happening hours together. I don't really take it as a seizure, because that's really, technically speaking, it's not possible to have that much time to have a seizure without any cognitive dysfunction. So it's supposed to be brief, and we know specific features of each and every seizure that arises from a particular area of the brain that depends on the lobe of origin, so which you have discussed already. So they'll have some specific features sometimes, and finally they can have a typical feature called as a Jacksonian march. So everyone would have been aware of what do you mean by Jacksonian march. So let's see. Let me try to show what do you mean by Jacksonian march. So what do you mean by Jacksonian march? You have this motor homunculus, basically, to start with. So as far as the motor homunculus is concerned, we have seen this already. You're going to have the feet here, then you have the knee here, then you have the hip and the trunk. So which means the lower limbs are the ones that are in the most medial portions. We have seen that is the reason why acetylcholine infarcts really affect the the lower limbs predominantly, because like this is the supply of by the acetylcholine. But nevertheless, we don't want that. So what do you mean by Jacksonian march? Is a seizure, a focal seizure that is originating from the lower limbs. For example, focally, if it's originating from the lower limbs, slowly it can spread along the motor homunculus, can get onto the face. So that's kind of a march. So it starts in the lower limbs, then upper limbs, then slowly it comes to the face. So that's a kind of a Jacksonian march. So then, or a seizure can start in the reverse direction also. For example, it can begin in the tongue and the larynx. So which means the tongue and the larynx are the usual sites you can see. It's the first site at this point. So tongue and the larynx. So that is what we refer to as vocalization. They can cry, they can make a sound. So it starts there, then slowly it can move to the other areas to involve the lower limbs and the upper limbs typically. So that typically follows the motor homunculus, and this is what we classically refer to as something called a Jacksonian march. So this type of pattern, not always present. So typically, again, you should not tell that it is present in all the patients, not always present, but presence of Jacksonian march also tells you that it could be a probable seizure and epilepsy. So that's why this understanding of Jacksonian march plays a key role. And we have certain types of generalized seizures, like for example, absence seizure. That's very important to know because it happens in children. But many times this absence seizure is something that is confused with focal epilepsy and focal seizure. That's why usually, as far as exams are concerned, we need to differentiate between the absence seizure versus a focal seizure with impaired consciousness. Focal seizure with impaired consciousness. So how will you differentiate? Because absence typically happens in childhood, but focal with impaired consciousness you can get in. Focal with impaired consciousness you can get in any seizure type. Just 1 second, everyone is telling that to move up. So I'll just try to adjust my screen a little bit. 1 second. I think it must be fine now, right? So it won't be a problem here after, because I've adjusted the screen a little bit so that you won't be having any problem from now on. Okay, so you have absence seizure, and then you have focal with impaired consciousness. How to differentiate between absence seizure versus focal with impaired consciousness? The first one is the aura that you have. One of the important features of absence seizure, that's classical and childhood absence seizure, is absence of aura. You don't really get an aura. But focal with impaired consciousness, you will get an aura. And as far as the onset is concerned, absence tend to be very abrupt in onset, whereas focal with impaired consciousness tend to be a little gradual in nature. It won't be upset sudden, like that kind of remote kind of a situation where pause and play, that's absence. Suddenly they go for that pause kind of a situation and they will start doing their work normally after that episode of absence seizure. But focal is more gradual sort of thing. They have that initial lobar features, then they go to impaired consciousness, then they can go for that generalized tonic-clonic seizure type of a picture. So it's more gradual rather than having a abrupt onset. So as far as the termination is concerned, so absence again is going to be abrupt. So that's why I told you can imagine like a pause play kind of a situation where sudden pause of the brain, then you can start playing the brain. So it's like a remote control kind of a situation. So that's what is going to be classical feature of an absence seizure. And once again, even the termination is going to be gradual in the setting of a focal with impaired consciousness. So which means they're going to have some kind of post-ictal state where they will have that. And one more important feature of post-ictal state I didn't mention is myalgia, and they can have a severe fatigue after that. So they'll be lying down for a long time. So that's one other feature of a generalized seizure or a focal seizure or any seizure for that matters. But absence will not have that kind of a picture. So they'll be terminating more abruptly. And the total duration of the seizure, as far as absence seizure is concerned, it will be for less than 15 seconds, not more than that. Whereas focal with impaired consciousness, it will be for more than 30 seconds. So it will be for quite a little longer duration. Not even though like hours together, it will be like within 5 to 10 minutes only, but it will be more than 30 seconds compared to that of absence where it will be for less than 30 seconds. And more importantly, this post-ictal state also tells you whether it's an absence or a focal with impaired consciousness. So as far as absence is concerned, the post-ictal state will not be there. There will be no post-ictal state in the sense like, should not tell no post-ictal state. The post-ictal means after the seizure, the state what you get is the post-ictal state. It's a vague terminology. I'm going to tell post-ictal state is normal. That's what I'm going to tell, which means the patient will be looking absolutely normal. That's why I told you again, it's kind of a pause and play kind of a scenario. Focal with impaired consciousness, of course, the patient will be more confused and they will be more lethargic, and they'll be having severe fatigue, tiredness, myalgia, very common in this kind of focal with impaired consciousness or even other generalized kind of seizure. This picture is quite common. And as far as frequency is concerned, frequency is quite high. They might get up to 10-15 attacks in a single day, but you will not get that much high frequency in the setting of focal with impaired consciousness. Hyperventilation as a trigger is very common. And hyperventilation increases the risk of developing absence seizure. Hyperventilation has no effect in getting absence seizure. That's why we generally tend to provoke the seizure in the labs by asking the child to hyperventilate while taking the electroencephalogram, EEG. But anyways, so that's completely different. We'll be talking about that later on. Then what are the associated seizures? Associated seizure types in absence seizure. So they can, as I told you, they can degenerate to generalized form of seizures, very typically GTCS or probably myoclonic seizures. Then we have tonic-clonic types, but they really don't go to atonic type of seizure. That's one point that you need to note, because there will be no loss of postural tone as far as absence seizure is concerned. That's really, really important. But as far as the focal and partial seizure are concerned, there might be loss of postural tone. Might be, not always. There might be loss of postural tone, but absence seizures, one important fact is that they won't have that loss of postural tone. That's why I have not written any atonic seizure here. So they can degenerate other types of seizures, other type of generalized seizures, but atonic seizures are quite rare. They don't lose the postural tone basically. And that is the reason why absence seizure patients may not have any injuries with them, because the falls are very uncommon. So associated, we have something called focal onset seizures. This will be the associated seizure in this. So the onset you have to see from which lobe it is originating from. That will tell you from which area typically the seizure is originating from. That's a focal onset seizure. And as far as the electroencephalogram is concerned, so we know the classic EEG finding, that is 3 Hz spike and wave appearance. So this is something you have to memorize. There is no other option. This is a typical feature of an absence seizure. That's called a 3 Hz spike and wave pattern. Very classical. As far as the focal seizures with impaired consciousness is concerned, it's quite variable. You'll be looking of more of an epileptiform spikes. There is separate definition from what do you mean by epileptiform spikes, but it'll be getting in the area of origin. For example, it can be in the temporal lobe, it can be in the frontal lobe, it can be in the parietal lobe, it can be in the occipital lobe, depending on the site of origin. That particular area, you'll be getting epileptiform spikes. And it's very easy to localize the seizure on EEG, isn't it? Because EEG is something we place electrodes over the entire brain. You can pinpoint the localization of, pinpoint the origin of seizures based on the which lead it is showing the epileptiform spike. And as far as treatment is concerned, of course, we know for absence seizure, ethosuximide remains the gold standard. And this is a drug that is designed to treat seizures. Designed to treat absence seizures. It's a T-type calcium channel blocker. So, of course, it's a T-type calcium channel blocker, which we'll be discussing about it after some time. But nevertheless, this ethosuximide is a drug that is tailor-made to treat absence seizure only, which means ethosuximide will not be effective in other types of seizures. It's dedicated to treat absence seizures. Even though it is not widely available in India, very few centers in India are having ethosuximide. Now, few companies have started producing ethosuximide. Only for selected institutes, they are giving ethosuximide. But most of the areas, we don't really have ethosuximide as far as India is concerned, because of the manufacturing difficulties. And apart from that, we have something called atypical absence. So I told you, whenever absence seizure is associated with other types of seizure, it will be called as atypical absence. For typical absence, we have no doubt we are going to treat only with ethosuximide. As far as atypical absence is concerned, the most important part of the treatment is valproate. So valproate is one of the gold standard drugs for any generalized seizure, in the sense like it can treat absence seizure also. And at the same time, especially if there is association with other generalized forms of epilepsy like GTCS or tonic seizures or clonic seizures or myoclonic seizures, in that setting, we'll be using valproate. But remember, one important point to note is valproate is something which should be avoided. In children less than 3 years, it's absolutely contraindicated because of fatal hepatotoxicity that can happen in this age group. So please avoid valproate in children less than 3 years of age. Don't give. Valproate is contraindicated there. So most of the cases will be children. As far as the focal seizure with generalization or like the impaired consciousness is concerned, so the word focal means the usual best drug will be carbamazepine. But we don't use carbamazepine basically. Now we use another congener called oxcarbazepine that is having a little bit of better side effect profile compared to the original carbamazepine. But nevertheless, in exam, you cannot choose one among the two because both are like right eyes and left eye. And with the additional advantage that oxcarbazepine has a relatively lesser side effect profile, but it comes with a higher cost, of course. You can start with carbamazepine also. Both are okay. So these are going to be the drugs for focal seizures, any focal seizure, whether with impaired consciousness or without impaired consciousness. You can use other second-line drugs like, for example, topiramate can be an option. Levetiracetam can be an option. Levetiracetam can be an option, or even lamotrigine could be an option. Clear? But of course, any focal, the first line drugs will be carbamazepine and oxcarbazepine only. Ethosuximide for absence seizure. If it's atypical valproate, don't use in less than 3 years. It is absolutely contraindicated because of risk of fatal hepatotoxicity. I think this must give you a good idea about absence seizure versus a focal with impaired consciousness. And once again, as a part of review, the most important feature of absence is the absence of aura, onset and termination that is going to be abrupt, and there is no post-ictal state, and there will be no loss of postural tone and hyperventilation as the trigger, and this classic 3 Hz spike and wave pattern, and ethosuximide as the drug of choice. So these are the points that you have to at least be thorough before going to the exams. So it's a very common questions in exams about the absence seizures. Then as far as the JM is concerned, there's another seizure type called a juvenile myoclonic epilepsy. Very classic. In exam, they will be describing this as a juvenile. I mean, the name tells it's a juvenile. So it will be like a teenager or an adolescent. They will call it as early morning jerks. So very classic. Early morning jerks. These jerks are nothing but myoclonic jerks. They're sudden movements. Myoclonic jerks. Typically, they will be adolescent and teenagers. That's a juvenile age group. And this juvenile myoclonic epilepsy, in comparison with absence seizures, they have a very high risk of GTCS, generalized tonic-clonic seizures. And if you take the EEG, very classically, the electroencephalogram is going to show the classic 4 to 6 Hz spike and wave pattern. So this is a very important point as well. Remember, in absent seizures, you know they're going to produce the classic 3 Hz spike and wave pattern, whereas the JME, juvenile myoclonic epilepsy, is going to produce this classic 4 to 6 Hz spike and wave pattern. And treatment is going to be with valproate. I can start with lamotrigine also, not a problem. But the valproate is the best option, even though, there are many other options like benzodiazepines are also there. But benzodiazepines can treat the myoclonus, but they can not stop the recurrence of, your epilepsy. So not a very good option. So valproate is, of course, a good option and one of the best options to treat these guys. But the problem is there is a high risk of relapse and recurrence. They usually do not go for remission. There is a high risk of relapse even with valproate. So stopping therapy will be very difficult as far as JME is concerned. But why I'm telling this point is because this absent seizures is one of the easier seizures to treat, basically, in the sense they have a very reduced risk of relapse, which means it's easier to control and has a higher chance of remission and reduced chances of getting a relapse. So that's a classic and typical absence. But as far as JME is concerned, it's quite opposite. They are going to have a very high risk of getting a relapse, which means stopping the therapy is going to be very difficult. But absence, stopping therapy is little easier. You can stop even much faster compared to other seizure types. But absence is not that easy to stop. Nevertheless, let us start about let's talk about some of the EEG findings. It's not like ECG, so it's not very easy to really understand. But you can see this kind of an image, which will give you some idea about what is EEG. EEG is basically kind of like a ECG for the brain. We know that, and it's discovered by someone called Hans Berger. And you can see that there are 2-3 things which you have to note. We can localize where the seizure is originating from based on the leads that we have kept. So you can see there are certain leads that are telling that you can localize in the frontal region. And there are certain leads you can tell they are localizing the temporal region. And you can see there are certain leads which localize to the occipital region. And there are certain leads which localize to the parietal region as well. And there are certain leads which localize to the central areas. And these are the, of course, frontal regions again. So you can localize anywhere. So frontal, central, occipital, parietal, and temporal as well. So we can localize anywhere, not a problem. But more than that, one important point to note that is if you are on the right side, so usually you have this kind of even numbers, which you can see everywhere whenever you note, these are basically even numbers. So even numbers means you're dealing with the right side, and that's how we read the EEG. And whenever you see these kind of odd numbers, 3, 5, 7, 1. So if these kind of odd numbers, which means you're dealing with the left side. And on the other hand, if you're seeing this kind of Z, you're dealing with the exact center. It's not right, it's not left, you're dealing with the center. So that's a sort of an odd number that you're dealing with. So this is one thing that you need to note. So you can localize based on the letters like F, then you have C, T, P, O. So this tells frontal, temporal, parietal, occipital. Then you can see the numbers, the numericals. So if it's odd, think about the left side. If it's even, think about the right side. And if it's Z, think about the exact midline. So midline means it will be showing the letter Z. So, this is in short the terminology for the seizure. Orientation to the EEG, but nevertheless, the findings are going to be more important. So what are the important EEG findings that you should know as far as exams are concerned? There are some classic hallmark findings they'll be expecting from you. So one is called as a centrotemporal spikes. So this is a very classic interictal EEG finding that's called centrotemporal spikes. So where will you see centrotemporal spikes? Typically, you're going to see in a condition called a benign Rolandic epilepsy. Benign Rolandic epilepsy, that's classic for centrotemporal spikes. Remember, benign Rolandic epilepsy, even though the name tells benign, there is some risk of brain damage again in this type of epilepsy. So treatment will be done, and the best treatment is valproate, which I'll be telling you in some time. And at the same time, it is a seizure type that is going to happen in pediatric age group around 5-6 years. That's where it starts, where the mother starts noting that kind of seizure kind of a moment that happens while sleeping in the night. So that's typical benign Rolandic epilepsy. Childhood patient around 5-6 years, in the night, mother notes some kind of a focal movements in the limbs and the face. So they bring the child to the hospital. When you do an EEG, that's an interictal EEG. So you get this typical centrotemporal spikes, classical of a benign Rolandic epilepsy, and treatment is once again valproate only, because this is a generalized form of a seizure. And whenever they tell this temporal epileptiform spikes, or they just give temporal spikes or temporal epileptiform spikes, so this can have a multiple differential diagnosis. For example, of course, in an acute setting where the patient is having acute confusion state, I'll be thinking about herpes simplex encephalitis. We know herpes virus is something that has high affinity towards the temporal lobe due to unknown reasons. But when you see a patient with a fever, acute meningoencephalitis kind of a picture, and EEG showing temporal spikes or temporal lobe spikes or temporal epileptiform spikes, my diagnosis will be herpes simplex encephalitis only. Or in the setting of a seizure, in the clinical context of a seizure, you can think about a temporal lobe epilepsy as well. There are multiple reasons for having a temporal lobe epilepsy. One of the common reasons that are asked in exams is something called a mesial temporal sclerosis, which is one of the important cause of recurrent epilepsy and seizures in the world. But nevertheless, any epilepsy that originates from the temporal lobe is going to have a temporal lobe spike only. But the entire importance of that is not to forget the herpes simplex encephalitis as an important cause of temporal epileptiform spikes. And as far as absent seizures are concerned, we know that classic 3 Hz spike and wave pattern. That's very important. As far as juvenile myoclonic epilepsy is concerned, we are going to have 4 to 6 Hz spike and wave pattern. As far as Lennox-Gastaut syndrome is concerned, there is a childhood epilepsy syndrome called as Lennox-Gastaut syndrome. Very common question in exam again. You're going to have this classic slow spike and wave pattern, that is less than 3 Hz, otherwise referred to as slow spike and wave pattern. Less than 3 Hz spike and wave pattern. These are the 3 numbers that is very important for exam. 3 Hz, 4 to 6 Hz, less than 3 Hz for absence, JME, and Lennox-Gastaut syndrome. And Lennox-Gastaut is basically a triad to start with. So Lennox-Gastaut syndrome means you're going to have multiple seizure types. Number 1, multiple seizure types, and they can have developmental delay, that is low IQ. And third, they'll have classic EEG finding, that less than 3 Hz spike and wave pattern in the EEG. So this is typical Lennox-Gastaut syndrome. So in exam, whenever they give multiple seizure types in the same patient, same child, with a severe development delay and low IQ, and at the same time, if you have a less than 3 Hz spike and wave pattern, that's a slow spike and wave type of an ECG, then that's classical of Lennox-Gastaut syndrome. Very poor prognosis. Usually they die within a decade. And usual treatment, of course, is going to be valproate. Valproate is one of the very effective and broad spectrum anti-epileptic drugs. It's comparable to amiodarone of the antiarrhythmic drugs of the heart. Then, but of course, amiodarone, it comes with a lot of side effects. Similarly, of course, valproate is also going to come with a lot of side effects, which we'll be discussing subsequently. And we have other types of EEG, like you have something called a slow background with a periodic slow background with a periodic sharp wave. I think you have known this already. So if they give like kind of a slow background with a periodic sharp wave, so what is this EEG? So what is, which disease that this finding will fit into? We have studied this already. That's why I'm asking you. Yes, people who have listened carefully should answer this. Of course, yesterday we discussed this on the sporadic Creutzfeldt-Jakob disease, SCJD. Of course, yes. Sporadic Creutzfeldt-Jakob disease. Then we have the periodic slow waves. So instead of periodic sharp waves, you're having that kind of a periodic slowing. And this is typical of a SSP, that is subacute sclerosing panencephalitis. That's called a periodic slowing subacute sclerosing panencephalitis, also referred to as something called a Rademacher complexes. These are some form of questions that have been asked already. So Rademacher complexes, characteristic feature of a subacute sclerosing panencephalitis, which is typically like seen in the setting of a post-measles type of complications. After 15-20 years after getting a measles, you can develop this SSP, subacute sclerosing panencephalitis. And there is something called a PLED pattern. That's called a periodic lateralized epileptiform spikes. discharges. So that is periodic laterally sepaliform discharges called as pleds. You have unilateral pleds, you have bilateral pleds. So no matter what, pled is equal to seizure always. It's very specific for seizure. Periodic lateralized epileptiform discharges. And you can also get this sort of a midline spikes that will typically only in the midline. Midline means we're talking about this area, these Z areas. So if you're getting only spikes in the midline, so that usually go towards something called a supplementary motor seizures. Can show typical midline spike kind of an appearance. And there are two more EEG findings that you need to know. One is the high amplitude spikes with absolutely no rhythm, and it will be high amplitude in the sense it will be too much. So like it can fill off the entire EEG like this. So high amplitude, bizarre, chaotic. Like you can think about ventricular tachycardia or hyperkalemic rhythm in the ECG. So very high amplitude, bizarre EEG or bizarre rhythm, chaotic, you can call it any name. And they'll have literally no rhythm with them. So which means you cannot identify any rhythm, high amplitude, extremely high, bizarre, chaotic. So usually in this example, if the ECG tells like this, usually it will be infants that is less than 1 year of age. So you're going to diagnose something called a hips arrhythmia in this setting. It's a very classic pediatric question. So hips arrhythmia. So amplitude EEG is bizarre, chaotic, without any particular rhythm happening in infants, typical of an hips arrhythmia. It happens in something called infantile tremor syndrome, otherwise referred to as something called a West syndrome, infantile tremor syndrome, ITS, typical of a hips arrhythmia. And you have something called a diffuse slowing, which means your basic diffuse slowing is there. If it's a diffuse slowing means, slow waves generally means that delta waves. Delta waves are what we refer to as slow waves in EEG. Alpha and beta are actually very fast, and delta waves are basically slow waves in the EEG. So if you have a diffuse slowing, diffuse delta-ing, which means entire EEG shows this kind of full of delta waves. So usually that is suggestive of some form of a coma, or probably you can get in the setting of a metabolic encephalopathy. So coma means not all comas will have this kind of diffuse slowing, the delta wave formation, the entire EEG. So usually you will get something, exceptions are there. Like for example, you have something called an alpha coma, and you have a beta coma also, which means alpha waves and beta waves are basically high frequency rhythms. So that goes against the slowing, isn't it? So slowing means you should have delta throughout the EEG. But there are some exceptions where coma may have high frequency waves like alpha coma and beta coma. So alpha coma basically happens in sepsis. Severe sepsis induced coma may have an alpha waves throughout the EEG. That's called an alpha coma. And typically the beta coma, very commonly asked question exam, that happens in benzodiazepine toxicity or benzodiazepine poisoning. So, EEG is not like what you think. Sometimes you might be thinking that benzodiazepines are going to slow down the EEG because they are depressants of the brain. Not like that. That's why remember by the mnemonic called B for B. B for benzodiazepines. In benzodiazepine toxicity, you will get in a excess beta waves. Excess beta waves are a feature of benzodiazepine toxicity. B for B. Clear? Beta coma can happen in benzodiazepine poisoning or benzodiazepine toxicity. As far as I know, these are the 11 very important patterns and 11 very important key points in exam that will tell you that the patient is probably having a particular type of a seizure. To localize these 11 findings, I think are more than enough, and more than 95 to 98% of the questions will be coming from these 11 patterns, whatever I told you, something or the other. And this is how it is. And ultimately, even if you read the entire EEG, you will be coming out to this kind of nutshell only. That's what is going to happen, by the way. You'll be having a good understanding of EEG if you read EEG books. There are many good EEG books are there. But ultimately, at the end, you will be making out certain points. Like in 2 pages, you can finish off the entire EEG, because those are the findings you are going to look for in the EEG if you want to diagnose a seizure. Many of them will be artifacts, non-specific findings. To understand that, your textbooks may be helpful. But ultimately, the distillation will be coming up to this, some 20 to 30 points. That's all, nothing more than that. Then next step is to differentiate the GTCS versus syncope. How will you differentiate a generalized tonic seizure versus syncope? That's very important, because you don't know seizure versus syncope differentiation. As far as the GTCS is concerned, we know they will have some form of warning symptoms, and many patients do complain this kind of warning symptoms. What are the warning symptoms are going to be? First, they will get something called an aura. That's called an epileptic aura. We know what is the aura means. That's a focal seizure. That's an aura. That will be specific depending on the lobe of origin. And this aura will be there. And in a short span of time, very short span of time, within some few seconds to minutes, they will become a tonic-clonic seizure. That's what is going to happen in the setting of a generalized tonic-clonic seizure. But on the other hand, syncope also will have some premonitory signs, premonitory symptoms. So here we not call warning, maybe you can call it as kind of a premonitory symptoms and signs. So, I mean, many of you would have experienced vasovagal syncope, isn't it? Many of you would have experienced vasovagal syncope. In that setting, everyone would have got that kind of a lightheadedness and kind of a feeling of a nausea, severe sweating, diaphoresis, and there will be someone in this batch who's attending the class would have experienced vasovagal syncope, especially in the school prayers, maybe standing for a long time in the sun. So you might be feeling a little dizzy and you fall down, isn't it? So that's quite common. It's a premonition. That's a premonitory symptom. And before getting that fall, typically you will get that kind of a lightheadedness, pre-syncope. And you know that something is going to happen for sure. So you will get nausea, sweating, that is diaphoresis. So little blurring of vision and suddenly you will faint off. So this is what is going to happen. As far as the muscle tone is concerned, they become stiff basically, like this kind of a tonic posture is very common. As far as muscle tone is concerned, the tone is going to be lost in a syncope, which means that will result in a consequent fall. And as far as the motor activity is concerned, you know, there's going to be clonic jerking. And whether motor activity is possible here or not, of course, yes, they can get, I'm writing plus or minus because not all the time, they can get a few myoclonic jerks as well. Myoclonic jerks as well. Why that point is important? Because many times you might be thinking that this jerking and shaking is specific for seizure. No, that body shaking has multiple differential diagnoses. Even Parkinson tremors, if it's violent, can produce a kind of a shaking. So, I mean, many extrapyramidal symptoms also come with shaking. Even brain hypoxia. That's what happens in a syncope. For example, in a vasovagal syncope or any cardiogenic syncope. So there is a brain hypoxia. That's why you fall. That's why you have a loss of consciousness. So during that time, hypoxia can induce a sort of myoclonus. So that can produce a small amount of jerking. So just the presence of jerks or the absence of jerks is not going to tell you whether it's a seizure or a syncope. So that's one of the very invalid points in clinical practice, to tell that jerks are there, so it's a seizure. No, it can happen in many other conditions. But the duration of jerking matters. Let us come back to that. As far as the patient's skin color is concerned, skin color will be typically normal. And here, because of severe hypoxia, they'll go for pale appearance because there'll be hypotension, bradycardia during vasovagal syncope. So the skin will become pale. And the duration of LOC, duration of loss of consciousness, will be short again in a seizure, but it will be more than 1 minute at least. But less than 5 to 10 minutes, of course. But here, the duration of LOC will be for less than 1 minute. That's very important point. So that is going to give rise to the next point, that is recovery from unconsciousness. Recovery from unconsciousness will be a little late here, whereas it will be extremely early and fast. And there will be no postictal state if it's going to be a syncope. If it's going to be a GTCS, definitely there will be a postictal state. That's why I told you recovery from unconsciousness will be a little late. But whereas recovery from unconscious or recovery from the seizure postictal state will be very, very less. So they will recover much, much, much faster. You would have simply experienced your, like vasovagal syncope, where in the school prayer, one kid has fallen down, you take to the room, just elevate her limbs, increase the blood flow to the brain and the heart. They get better. And of course, within 2 minutes, they stand up and they will tell, I'm okay. And maybe even though you ask them to take rest for a few minutes more, but they will be okay to go up and running. So that's how a syncope is going to be. It's going to be early and a fast recovery from unconscious state. And if at all, from among all these things, if you tell the most important finding, like that differentiates a seizure versus syncope is the last one. So that's going to be the most important of all. And that's the one that can concretely tell that it's likely to be a seizure or likely to be a syncope, that recovery from unconsciousness, that is delayed or fast. So that's the typical entity, and that's the most important one as well to differentiate. I think we have 2 more things left. One is going to be the treatment, number one, so of seizures. So where you have a variety of anti-epileptic drugs to treat. And next thing, what we need to know is the choice of the treatment. So which seizure type should be treated with which particular drug type. And there are a lot of tables are there, very confusing tables, and a very daunting table is there. First line, second line, third line. But it's very simple. We decide based on the patient, and we use stereotypically very few seizure drugs that are effective for most of the seizures. And at the same time, we have to consider side effects, age group, cardiac effects, hepatic effects, renal effects, their enzyme inhibitory function, whether the patient is taking other drugs or not. So it's a sort of a clinical decision rather than a drug of choice, which I really hate. Of course, it's more of a clinical decision. You have to consider what are the comorbidities, what is the current status of the patient, and like all the hepatic and renal side effects, and consider all these things and start a particular drug. So as far as the anti-seizure drugs are concerned, you can divide into basically two. So one, you can divide into either a form of drugs that inhibit the excitatory potentials. Of course, yes. So that's why they reduce the neuronal activity. Or there are some kind of drugs which can increase the inhibitory potential. So which means either increase inhibition or reduce the excitation. So most of the drugs are going to work similarly in that particular fashion. So let us draw the presynaptic terminal. This is a kind of a diagram you will see in many pharmacology textbooks. Let us understand it easily. So this is sort of a presynaptic terminal, and I can draw the postsynaptic terminal maybe here. So this is a postsynaptic terminal. So I think it's better we put a kind of a central line that demarcates that this side you're going to have inhibition. Inhibition or inhibitor neurotransmitters. On the other side, you are going to have this kind of excitatory transmitters. So I can write in green. So because they're excitatory, they're going to cause excitation. And the glutamate is going to be one of the most important excitatory transmitter. And of course, the GABA is going to be one of the most important inhibitory transmitter as far as the central nervous system is concerned. So there are many channels out there. For example, you have this kind of potassium channels, which can move the potassium out. And when you increase the movement of the potassium out, the cell will be hyperpolarized, resulting in poor propagation of depolarization, and there will be acting as an inhibition. So that's why I'm writing on that side. So these channels are nothing but KC and Q channels. And we have calcium channels. So, and we clearly know that these calcium channels are going to push calcium into the presynaptic terminal, so that these calcium can act on the vesicles that contain GABA, for example, and they can release GABA. Clear? They can release GABA. So this is one way to increase the GABA, and at the same time, this GABA that is released into the synaptic terminal can be taken up back by a reuptake transporter called as GABA transporter, or GABA reuptake transporter called as GAT1, which is also very important target for certain drugs, which we'll be discussing in some time. And this GABA is going to act on the GABA receptor. So, and the most important GABA receptor, as far as we know, is the GABA A receptor. So I can draw, this is going to be probably the GABA A receptor. GABA A receptor, and of course, this is going to push the chloride inside. So that's a negative ion. So there are a lot of drugs that can act at different places. So let us start with our drug that is going to increase the activity of this KC and Q channel. That's going to increase the potassium efflux, thereby causing hyperpolarization of the cell, thereby causing reduced transmission. So that is retigabin. And we have drugs that activate this calcium channel so that they can increase the release of GABA. These are GABA-specific calcium channels. These drugs are nothing but gabapentin. And we have another drug called pregabalin. Both drugs are going to act in a similar fashion, gabapentin and pregabalin. And these are going to work on the alpha and delta subunit of this particular calcium channel and cause increased release of GABA. And at the same time, you have a drug that can inhibit this GAT1 transporter so that you can increase the synaptic concentration of GABA. So that drug is called ticabin, of course. And you also have certain drugs that increase the concentration of GABA directly in the synaptic space. That is called as vigabatrin, which has a lot of visual side effects, which we'll be discussing after some time. So that's vigabatrin. And you can also increase the function of this benzodiazepine receptors, that is GABA-A receptors. There are two drugs we know classically that increase the function of this GABA-A receptors, that is benzodiazepines, and second is the phenobarbital. So there are two drugs are there in this group. And you have an exhaustive list of anti-epileptic drugs on this side also, but these are the common mechanism of actions, how the anti-epileptic drugs are going to work upon. Apart from that, you have some excitatory neurotransmitters also, which can be inhibited. The first one, of course, is going to be this voltage-gated sodium channels, which can be inhibited by a variety of drugs. In fact, if you ask among all the anti-epileptic drugs, the most common action will be on this sodium channels only. So the excitatory, the inhibition, the blockade of the excitatory function of the neurons. So that's the most common type. Where was roticotin? Wait. So roticotin is a different drug. So I'm not going to draw here. So sodium. So sodium channels are there. And apart from that, you have this kind of sodium entry into the cells. So this sodium entry is going to cause depolarization. And this depolarization is going to release the vesicles of glutamate, for example. So that's the most important neurotransmitter, excitatory neurotransmitter as far as we are concerned, glutamate. And to produce this glutamate and to produce these vesicles, you need a very important transport protein that is called as SV2A. SV2A transport protein is there, and that is the one that is basically going to produce this pack this glutamate into vesicles, and that's why there are some drugs which act on this SV2A transporter also. And once this glutamate is released, this glutamate can work on variety of receptors, because the two most important receptors for glutamate is AMPA receptors, and second one we have something called a kainate receptor. So first let us talk about the AMPA receptor, which is basically ion channel receptor, which is going to push sodium. I think I've told about AMPA in the stroke pathophysiology itself. Then we have this kind of KCNQ channels also, which is basically a potassium channel. And at the same time, we have some NMDA receptors also, which is also glutamate receptor only, which can push in sodium as well as calcium. Again, I've told you about this AMPA and NMDA kainate receptors in the stroke pathophysiology itself. Now, as far as the sodium channel inhibition is concerned, so there are some drugs that inhibit the sodium channels so that you can prevent the depolarization and release of the excitatory neurotransmitters, as well as the overall, you can reduce the depolarization firing of the neurons. So the classic drug that works is phenytoin. Anyway, we no longer use phenytoin in clinical practice, but nevertheless, very important drug to know. Then carbamazepine works by this, oxcarbazepine works by this. Then we have lamotrigine, very important drug that is used in clinical practice, that also works by this principle only. Then we have other drugs like rufinamide. So this is a drug that's been asked by many times names, because this rufinamide is a sodium channel blocker only, but this is a drug that is tailor-made to treat Lennox-Gastaut syndrome. Remember, Lennox-Gastaut syndrome, still the treatment of choice will be valproate only. I'm not denying that fact. But this rufinamide is a drug like ethosuximide. How ethosuximide is tailor-made for treating absence seizure, like that rufinamide is a drug that is tailor-made to treat your Lennox-Gastaut syndrome. So that's why that drug is important. Apart from that, it doesn't have much role in clinical practice as no. Then we have a lacosamide that works by this principle. Then we have even zonisamide that works by this principle. Then we have a very, very new drug that's called the eslicarbazepine. So I can write as an alternative here. That's a eslicarbazepine. that also works by this principle only. But commonly what we use is carbamazepine, oxcarbazepine, lamotrigine, and probably to an extent we use zonisamide as well. So these are the drugs that we use commonly in our clinical practice in India, but nevertheless all these drugs are very important to know. And we have drugs that can inhibit this sort of packaging transporter, that's SV2A inhibitors. So we have levetiracetam for that, and we have bivaracetam. But we know commonly what we use is the levetiracetam only. Bivaracetam is not very commonly available in India. Levetiracetam is one of the very extensively used anti-epileptic drugs as far as Indian practice is concerned. And now you can actually increase the activity of the potassium channels, causing movement of potassium out, so that you'll be resulting in hyperpolarization of the postsynaptic terminal, thereby reducing the action potential transmission. So that drug we know already, we know it is reticabin. Same drug which we have studied, which acts on the KC and Q channels. And we have some drugs that work on the AMPA receptors and inhibiting the AMPA receptors. These drugs are basically topiramate, and we have another drugs called perampanel. And of course the topiramate is going to be the most important and a very commonly used drug as far as Indian practice is concerned again. And of course we have an NMDA receptor blocker as well. So in the form of felbamate, very rarely used drug in clinical practice, but still important to know, felbamate. I mean, you might be surprised that I have not told valproate yet, because valproate is like amiodarone. It's like a very broad spectrum anti-epileptic drug which can act in multiple different areas. So it's a very like broad spectrum drug, so it can actually have multiple effects. So no need to tell valproate in this particular diagram. So nevertheless, you will be easily understanding, because this will not be a question usually in exam, because unless and until you get a typical pharmacology question where they ask the mechanism of action. I don't really like this kind of diagrams, because mechanism of action is something that is not important for me in clinical practice. And I don't think in the current exams you will be getting a lot of mechanism of action kind of a question. But still, as far as the second year, third year and final year students are concerned, their entire pharmacology lies only on mechanism of action. So once they know the mechanism of action, a second year student will believe that they know the pharmacology. But it's not like that. It's all about the side effects and the appropriate therapy. The clinical pharmacology is the most important point. But how much ever times we substantiate this particular point, they don't realize. All they need is the mechanism. Of course, and few mnemonics, that's all that completes the pharmacology for them. But anyways, so for those people, this diagram will be very helpful. So this is a single diagram you can go through before the exam. It will be very easy for you to understand. Then we'll be moving on to the side effects. So what are going to be the serious side effects? So, I mean, first we need to know what are the serious side effects that you can expect. So one is the rash and the Stevens-Johnson syndrome. So this is a very serious side effect with a lot of anti-epileptic drugs. And two drugs produce highest risk. One is carbamazepine and its congeners, that is oxcarbazepine. Even though oxcarbazepine has a little bit of lesser risk of developing Stevens-Johnson syndrome compared to carbamazepine, but carbamazepine is on the top of the list. And we have some HLA molecules that depict the risk of carbamazepine-related Stevens-Johnson syndrome, which we'll be discussing later on, along with allopurinol rheumatology, I will tell you. Then we have phenytoin, which can do the same. Then we have lamotrigine, which can do the same. They can get severe rash in Stevens-Johnson syndrome, and it can be seen to an extent with phenobarbital as well. But as far as the current practice is concerned, these are the two drugs that we use very commonly. So that's why it's important to understand about those two drugs. Second one is marrow failure, bone marrow failure resulting in severe cytopenias. So of course, again, carbamazepine stands tall here. And second drug that can do that is felbamate. Of course, in this, carbamazepine is going to be a very important clinical pharmacology point as far as exams are concerned. And they can result in severe hyponatremia. And this hyponatremia is due to SAADH, increased ADH release from the brain. And of course, again, carbamazepine and oxcarbazepine stands tall. And carbamazepine is going to be the most important again. In fact, I will tell you in endocrinology, carbamazepine is a drug that is used in some diabetes insipidus cases to increase the release of ADH from the brain. So it can be used as a treatment for that, because carbamazepine is well known to produce this increased ADH release from the pituitary, posterior pituitary. So that's a very important side effect, hyponatremia. Then visual field effects, visual issues. Of course, when I tell visual, V always stands for vigabatrin. Visual. Vigabatrin is a very important drug that is associated with visual defects. And we have psychiatric effects, depression and psychosis. One drug that stands tall, rage attacks, angry, patients getting increasingly angry, levetiracetam. Levetiracetam, very, very important drug, and that's going to stand tall, and perampanel can cause, but I don't really think that's very important for our practice. Levetiracetam is the very commonly used drug in Indian setting. So these are some serious side effects. I usually ask this history very commonly, especially when a patient is taking levetiracetam. I ask their family members, are they getting increasingly angry over a period of time? And of course, yes. Levetiracetam is something that causes these kind of rage attacks, anger, depression, psychosis. So very, very important drug and a very commonly used drug as well, levetiracetam. And sixth one, there are some drugs that are very dangerous in pregnancy. Pregnancy, if I want to avoid one particular drug, or in the patient with reproductive age group, if you want to avoid one particular drug, I'll not use valproate. Among all the anti-epileptic drugs, this has the worst teratogenic potential and maximum side effect, of course. You can remember among all the anti-epileptic drugs, valproate has the highest side effects like amiodarone. At the same time, it has one of the worst teratogenic potential as well. Almost 4% risk of being teratogenic, which means 1 in 25 children will be born with some kind of congenital malformation, which is very worst actually compared to other drugs. And many students do ask me, what is the safe drug for pregnancy? For me, there is no safe drug for pregnancy. Literally, there is no safe AED. There is no safe anti-epileptic drug in pregnancy, to be honest. So you cannot tell even a single anti-epileptic drug that is safe in pregnancy. But it doesn't mean that you have to stop all the anti-epileptic drugs. You have to give an anti-epileptic drug with a lower risk of teratogenic potential. That's the idea. And at the same time, you have to see the benefits versus risks. For example, let us take two scenarios. A patient who is well controlled with, having a refractory seizure type, but is controlled only with valproate. There is no other option, because if you stop valproate, the patient will get seizure again, and such a patient is going for pregnancy. So in that setting, I might be feeling that it's better to continue with valproate, even if it's teratogenic. Still, it's 1 in 25 chance only. But remember, if a patient gets a seizure during pregnancy, there is almost 50% chance of stillbirth or 50% chance of getting aborted. So considering the abortion risk and the stillbirth risk, continuing valproate is better, at least. Maybe if you do a second trimester scan, if they see major congenital malformation, you can do some MTP or surgical abortion. But anyways, so in that setting, getting a seizure is actually worst. It's going to affect the mother as well as the child in a very bad way. So in extreme scenarios where I will not be able to stop some of the anti-epileptic drugs, despite being the fact that it is teratogenic, we might be continuing that drug. So it all depends on the benefit versus risk. We don't have any particularly safe drug in pregnancy, but still we have to continue some drug. For example, if you are giving a drug and that is controlling the seizure very well and you don't find any difficulty in controlling the seizure, but unfortunately patient is on valproate. In that setting, if it's not a refractory seizure type, you try to discontinue valproate and you try to give a less teratogenic drug, for example, like levetiracetam or lamotrigine. So you give a less teratogenic drug, which we'll be discussing. You try with that drugs. And if that drugs control the seizure, that's okay, fine. You continue with that drug, which means it's lucky. The seizure is being controlled with that less teratogenic drug. So that's fine. So suppose if the seizure is not controlled with the newly given drug, then there is no other option. You have to shift back to the older drug. Even if it is teratogenic, we have no other option, because having a seizure during pregnancy or having seizure at any point in life is actually more deleterious than this kind of pregnancy-related teratogenic effects and all. So right now, we don't have any universally safe universally safe non-teratogenic anti-epileptic drug. At the same time, the choice of anti-epileptic drug in pregnancy depends on whether the seizure is controlled or not. Depending on what is the status of the seizures and whether it is refractory or not. So a lot of things you have to take into consideration, and you cannot tell that this is the drug of choice I'll be using in a pregnancy as far as seizures are concerned, because nothing is safe, to be honest. So first, valproate. Still, there are a lot of pregnant women where I have seen taking valproate because they have a refractory seizure, only controlled with valproate. You cannot do anything. But among all the anti-epileptic drugs, valproate becomes the worst teratogen of all. 4% risk of being teratogenic. And you have phenobarbital, which is also one of the worst drugs. It's better to avoid in pregnancy if you think you can get rid of it, because the mental retardation. In the sense, I don't call mental retardation really, but you can get a low IQ state in the setting of a phenobarbital. The child will have a lower IQ overall. And apart from that, even topiramate is not a very good drug. It's better to avoid these drugs in the childbearing age or in pregnancy, so which can result in cleft lip and cleft palate. Cleft lip and cleft palate. And if you talk about a relatively safe drugs in pregnancy, I will be probably going towards a lamotrigine, which can be effective for a variety of seizure types. Safe and relatively safe. Now, I'm not telling absolutely safe. Relatively safe in pregnancy. Then levetiracetam, relatively safe in pregnancy, and we have carbamazepine and oxcarbazepine, relatively safe in pregnancy. The safety decreases in this zone, which means the most safest, if you ask, is lamotrigine, then followed by levetiracetam, then followed by carbamazepine and oxcarbazepine. Please understand that these, even if you consider this as safe, they have a higher risk of developing neural tube defects. So in order to avoid the risk of developing neural tube defects, you have to give extra folic acid. Folic acid supplementation should be given extra. Usually you give about 0.5 milligram per day, but here you have to give up to 1 to 4 milligram per day. In our Indian setting, we tend to give up to 5 milligram per day folic acid. We always give in excess, isn't it, if it's a vitamin supplement or nutritional supplement. But nevertheless, like up to 1 to 4 milligram per day folic acid must be needed, and it will be required if you're using any one of these drugs in pregnancy, because still these drugs have a little higher risk of developing neural tube defects. Among all these drugs, higher risk of developing neural tube defects is with carbamazepine, oxcarbazepine. So in that setting, I have to give 4 to 5 milligrams per day of folic acid. All right. So these are some of the serious side effects as far as your anti-epileptic drugs are concerned. Now moving on to what are the drugs that will be probably using in older individuals. Suppose if I'm having a geriatric patient, older individual, old patient, so what are probably the drugs that I can choose? So for older individuals, I can use carbapenem, or probably I can use a lamotrigine, which is relatively safer in older individuals. And at the same time, I can use levetiracetam as well. So these are some of the drugs that I can prefer in older individuals. But remember, it is better to avoid carbamazepine, because if you give carbamazepine, there is a higher risk of hyponatremia. Already there is a high risk of hyponatremia in older individuals. And if you're going to give these drugs, it's going to be even more worse, and the falls rate is going to be high, and the fracture rate and subdural hematoma rates is going to be higher with carbamazepine. There is one trial that is proving that as well. So avoid other drugs, and better to start any one of these 3 drugs depending on the particular seizure type. And we have a lot of drugs where you need dose adjustment in renal failure. So what are the drugs that has to be adjusted in renal failure? Which means you have to do dose adjustment in renal failure, which means these drugs can be renally excreted. The first drug is gabapentin again. Second drug is pregabalin. And the third drug is going to be levetiracetam. So these drugs, it's better to use dose adjustment in renal failure. And in liver dysfunction, what are the drugs that needed to be dose adjusted? In liver dysfunction, of course, the one important drug that has to be avoided or probably adjusted in the dosage schedule is valproate, because valproate has severe serious side effects and they can produce liver failure in many people. One of the important causes of fatty liver and steatosis of the liver, and at the same time they can cause acute liver failure as well. Valproate is a very important drug in that entity as far as the liver is concerned. Then we have the phenobarbital, which can produce liver dysfunction. So dose has to be adjusted very carefully, and even carbamazepine dose has to be adjusted carefully. And there are some drugs that are highly albumin bound, which means they are, because of that, their dosages may be needed to be given high because they are very highly albumin bound. So that's why phenytoin, we give a loading dose, because you need to saturate albumin first, then the free levels only will act as an anti-epileptic drug. That's why these 2 drugs need a high dose usually, phenytoin, valproate, and all this stuff. So they are highly albumin bound. And next question they might ask in exam is the enzyme inducers, because that's very important, because a lot of anti-epileptic drugs are basically cytochrome enzyme activators. So what are the enzyme inducers basically? Typical enzyme inducers include phenytoin, phenobarbital, and carbamazepine. These are old drugs. Phenytoin is an enzyme inducer. Phenobarbital is an enzyme inducer. And carbamazepine and oxcarbazepine is, of course, an enzyme inducer. And even topiramate is an enzyme inducer, of course. And the only medically important enzyme inhibitor is going to be valproate. Valproate is the only medically important enzyme inhibitor where you have to be careful whenever you are giving a drug with narrow therapeutic index, like probably warfarin or some other drug that prolongs the QT interval. In that setting, valproate has to be given carefully because they can inhibit the metabolism and increase the serum values of those drugs, causing either a prolonged QT interval and sudden cardiac death, or they can result in development of high INR in the setting of warfarin. Okay, only important, medically important enzyme inhibitor is valproate only. And there are some drugs, contrary to that, where they do not have any much drug interaction. In the sense you can give safely without thinking about other drugs on the list. So there's no significant drug-drug interaction. One is levetiracetam, better. They don't have significant drug interaction. Then we have lacosamide, no significant drug interaction. Then we have gabapentin, no significant drug interaction, even though gabapentin has to be reduced in dosage has to be reduced in renal failure patients. But as far as the drug interaction concerned, you don't have any significant pregabalin, no significant drug interaction. And you have zonisamide, no significant drug interaction. And if they ask you the most common side effect of any antiepileptic drug, the most common side effect will be cerebellar toxicity, mild tremors, and nystagmus. So these are extremely common with any antiepileptic drug. All the antiepileptic drugs can result in the development of tremors. That's really, really important. Can result in the development of tremors. Any antiepileptic drug. Cerebellar toxicity is one of the very, very common entity to start with. And in that certain drugs, they will be definitely asking side effects. Of course, I told you carbamazepin's important side effect is already hyponatremia. And there are some drugs that produce Stevens-Johnson syndrome and rash. There are some drugs that produce marrow failure. And there are some drugs that produce serious visual complications. But there are some minor side effects that have been asked sometimes. For example, one drug that is very important for exams where a lot of questions do come from is going to be on the topiramate. Where is that? Yes. We can see some of the important side effects of topiramate. And what are the important effects as well sometimes. One of the important and most common side effect is heavy sedation that topiramate produces. The patient will be keeping on sleeping. That's a common complaint. And poor cognition and their school performance. If you give in young children the school performance, because the concentration will be reduced in a very big way, attention span will be less after taking topiramate, and they cause heavy sedation. That's a very important and serious side effect when you're giving these drugs to an adolescent population. So you have to take that into consideration. And they can produce significant amount of weight loss due to a variety of effects that work on the weight losing pathways in the brain. So they can produce a substantial amount of weight loss, one of the important approved drugs for promoting weight loss. So that one is important. Then they can get kidney stones, nephrolithiasis, because they form crystals in the kidney, and they can cause something called reduced sweating, anhidrosis, possible with topiramate. And at the same time, they can produce psychosis also, but not like levetiracetam, but still there's a decent chance of getting psychosis, and they can worsen the closed angle glaucoma, or they can precipitate the development of closed angle glaucoma itself. So if a patient is having a closed angle glaucoma, it's better to avoid topiramate in that setting. But many students will be very, very concerned with these two side effects only, because as far as I know about the second year's mentality, these two are the side effects they will be usually concentrating more on. Other side effects they generally miss out. But I generally believe that this is the most important side effect in clinical practice, because that really, makes the patient less functional socially and emotionally as well. And as far as valproate is concerned, as the name, as I told you in the liver dysfunction, valproate is something that is highly hepatotoxic. It can cause hepatic steatosis to the setting of an acute liver failure, and they can even precipitate like a Ray's syndrome-like picture. If you have studied in liver, what do you mean by Ray's syndrome? They can even come like a Ray's syndrome-like picture. So if the patient comes with encephalopathy, suddenly after taking valproate, that's highly possible, because they are very, very hepatotoxic drugs. And this is the same reason why we avoid this use of valproate in children less than 3 years of age, because they have a high risk of development of Ray's syndrome already. So that's why we don't give in children less than 3 years. And at the same time, they can produce significant weight gain, one of the few drugs that produce serious weight gain. And at the same time, they can produce, because of the weight gain, they can result in other complications like metabolic syndrome and other obesity-related problems like hypertension, diabetes, and they can cause PCOS also. This is one of the AIMS questions that have been asked in 2013. So anti-epileptic drug that causes PCOS in ladies, that is valproate. Because of the significant weight gain and insulin resistance they produce, they can do all these things. Apart from that, they can produce a variety of side effects like alopecia, osteoporosis. So usage in elderly women is not that good, because that's why I told you in elderly women, elderly people, safe is these 3 drugs. I would not have told valproate, because valproate causes osteoporosis and it's not very safe in elderly people. And they can produce pancytopenia as well. Not a very common side effect like carbamazepine, but relatively rare. They can produce pancytopenia as well. So some important side effects as far as valproate is concerned. Then what about phenytoin? Phenytoin is one of the very old drugs with so much of side effects. And the very important side effects, if you give phenytoin in IV route, everyone knows that, because it's a highly thrombophlebitic drug. So which means they can cause significant amount of thrombophlebitis. And sometimes even massive IV injections can result in a scenario. If you give without dilution, you can produce something called a purple glove syndrome. You would have heard about that. So that's extravasation of phenytoin because of severe thrombophlebitis causing necrosis of the superficial skin, resulting in typical cyanotic appearance of the entire dorsum of the hand, called as something called a purple glove syndrome. You'll be knowing that. Apart from that, phenytoin can result in other problems, especially if you give IV. They can result in bradycardia. They'll result in hypotension. You should be aware of that. Why bradycardia and hypotension? Because phenytoin is regarded as a class 1B antiarrhythmic drug, and we know that. So even though we don't use for that purpose, so it can have some cardiac side effects like bradycardia and hypotension, because it's considered to be that kind of 1B class 1B antiarrhythmic, even though lignocaine is a commonly used drug in that setting, and it can cause a serious cerebellar toxicity. And phenytoin is one drug with a narrow therapeutic index, so measurement of phenytoin levels are very important. You should keep the levels within 10 nanograms per ml. If it's more than 20, the risk of getting toxicity is very high. So it's a drug with a narrow therapeutic index, of course. So cerebellar toxicity, and itself it can produce osteoporosis, so avoid in elderly people. And people who are prone to develop osteoporosis, like people who are already getting steroids, and B12 deficiency is quite common. In exam, there are 2 drugs that they will very commonly ask about B12 deficiency. One is metformin and second is phenytoin. Phenytoin can well cause B12 deficiency as well. Very important question again in exam. And they can produce gum hyperplasia, hirsutism. I mean, you really want to tell gum hyperplasia and hirsutism. And due to unknown reasons, undergrad student usually concentrates only on these 2 side effects, which should be the last and which should be the least dangerous. They usually concentrate only on that 2 side effects, gum hyperplasia and hirsutism. They forget all the other side effects which the phenytoin is going to cause, of course. So I feel like this B12, osteoporosis, cerebellar is very important, and IV causing all these 3 side effects are very, very important. That's why we don't use really phenytoin now very commonly, because of the relatively higher risk of getting side effects, and we have many more effective drugs that have been coming in the market right now. And what are the other drugs that are important? As far as levetiracetam is concerned, levetiracetam, as I told you, it can produce a sort of psychosis and depression. That's very important. Irritability, that kind of rage attacks, that anger kind of an attacks. Then they can cause psychosis, suicidal ideation. So more of psychiatric side effects. So psychiatry means always levetiracetam should come into the first picture. So you can have a kind of a suicidal thoughts or suicidal ideation. Clear? So most of them will be psychiatric side effects only. As far as zonisamide is concerned, zonisamide can produce sort of side effect like similar to topiramate only, because topiramate and zonisamide we can keep hand on hand, because mechanism of action may be a little different, but overall topiramate and zonisamide are going to behave similarly because they're like similar molecules. They can also induce a type of weight loss, but even though it's not an approved weight loss medication like topiramate, they can also induce a weight loss, and they can also produce, like topiramate, heavy sedation, and they can produce poor concentration and poor cognition, and they can produce nephrolithiasis like topiramate, and they can produce anhidrosis, and at the same time they can produce or worsen closed angle glaucoma, and they can produce a sort of depression and psychosis as well, but it's not very common like that of levetiracetam. So which means all the side effects of zonisamide are extremely similar, isn't it? So which means if they ask you 2 drugs that promote weight loss, I will go for like your topiramate and zonisamide, and 2 drugs that produce nephrolithiasis, topiramate and zonisamide. Highly hepatotoxic, valproate, and highly teratogenic, valproate again, 4% chance, and child less than 3 years, contraindicated drug, valproate, anti-epileptic drug that can precipitate a Rey syndrome-like picture, valproate again, which can produce psychiatric side effects predominantly, levetiracetam. Avoid in elderly, phenytoin, valproate, because of the risk of having osteoporosis higher in elderly people. So risk is high. Carbamazepine also should be avoided because false risk is very high in elderly. And what are the drugs to be reduced in? Dose should be adjusted in renal failure. Dose should be adjusted in liver dysfunction. What are the drugs that can cause Stevens-Johnson syndrome, bone marrow failure? All these are questions, which means you have to take all these things into account, whatever I have told you. And you have to consider what are the drugs that the other drugs that have been taken by the patient. And after all these things, you consider the weightage and start an anti-epileptic drug. But nevertheless, it will not be complete if I don't discuss 2 more important things. That is what are the first line and the second line drugs, because every student wants to know this. What are the first line, second line drugs for seizure? Because how much ever times I tell that it's the clinical decision, they don't really understand. And they wanted to ask again and again, what is the first line? What is the drug of choice? What is the second line? So for that, I can tell the seizure type, and I can tell what is the typical first line, what is the alternative drugs for this first line. So first we'll start with the focal seizures. As for the focal seizure is concerned, the first line is going to be the carbamazepine or oxcarbazepine, even though I will weigh oxcarbazepine a little higher because of the side effects is little less, and you can use lamotrigine, or you can use levetiracetam also. It works. Levetiracetam. One drug if you want to choose, I'll be choosing oxcarbazepine in this particular setting. Then alternative drugs, you can use topiramate, you can use zonisamide, and of course you can use gabapentin, and you can use pregabalin as well. Remember, phenytoin we generally tend to avoid. I mean, these are more broad spectrum drugs. Phenytoin, valproate we generally tend to avoid in focal seizures. Sometimes phenytoin can even worsen the focal seizures. So one drug if they ask you which you should not use, I will go for phenytoin, because there is a considerable evidence that phenytoin use in focal seizures may actually worsen the focal seizures rather than curing it. So you don't use phenytoin for sure. Second is generalized seizures. You have different types of generalized seizures. Generalized seizures. For any type of generalized seizure, the first line is valproate, but even though it has serious side effects, so we can consider alternative drugs like levetiracetam. So in my practice, I use levetiracetam ahead of valproate because of the substantial high risk of side effects with valproate. Still, if you want, you can use. And you can use lamotrigine also, but lamotrigine has one problem. Even though it's very, very effective in majority of the seizure types, but it can worsen myoclonic seizures a little bit. Might worsen, not always. It might worsen myoclonic seizures. So that's why in myoclonic seizures alone, it's better use valproate or levetiracetam. Don't use lamotrigine. But all the other seizure types, you can prefer using a lamotrigine, no problem. Then ethosuximide. Ethosuximide is one of the first line drugs, but only for one seizure you can use ethosuximide. That is for absence. Only for absence. You're not going to use ethosuximide for other seizure types. And as far as the alternative is concerned, you can use topiramate, and you can use zonisamide. These are also effective for GTCS. Some of the few drug choices that you can prefer for focal as well as generalized type of seizures. As far as generalized type of seizure is concerned, I'll be avoiding carbamazepine and oxcarbazepine, which can worsen the GTCS. Pregabalin and gabapentin also better to be avoided in a generalized seizure. Especially GTCS, you avoid these drugs. Carbamazepine, oxcarbazepine, gabapentin and pregabalin. They might worsen the generalized tonic seizure according to the studies, so don't use those drugs in generalized seizures, especially generalized tonic-clonic seizures. It's better to avoid them. So suppose if the patient is having a focal with secondary generalization, then in that setting, you can prefer carbamazepine to prevent the focal seizure in the first place. That is the one that's going to spread into the other areas. So, or you can use valproate to be very, very safe in that setting. So still in focal with secondary generalization or focal or complex partial seizures we call with, in that you can probably prefer using a carbamazepine or oxcarbamazepine. But still in my clinical practice, if you ask me, I will weigh valproate more than other choices, because whenever you encounter the word GTCS, I'll be a little scared to give like carbamazepine, oxcarbamazepine, pregabalin and gabapentin for that purpose. Then finally, the discussion will be complete if we are going to discuss on something called status epilepticus. Status epilepticus. So what is the definition of status epilepticus? I mean, there are two definitions. One is seizures more than 5 minutes, any seizure activity that is persisting for more than 5 minutes, or it's or only, or if there are at least 2 seizures that are happening consequently, like one after the other, without any recovery of consciousness in between. Recovery of consciousness in between, either a single seizure lasting for more than 5 minutes, or a couple of seizures that is happening, or 2 or more seizures that are happening, but without any recovery of consciousness in between. So this is what we refer to as status epilepticus. Okay, so then how will you treat these patients? So these patients, first of all, you see whether the IV line is available or not. That's the most important point. So this is a very practical thing. Look for whether IV line is available. Or IV line is accessible. So IV line is not accessible in the sense like patient may be violently throwing seizures and you cannot put a IV cannula. So if IV line is inaccessible in that scenario, it's a very common scenario many times. So in that setting, you can go for a rectal diazepam. Rectal diazepam could be an ideal option in this setting. Suppose if IV line is easily accessible, which is also an extremely common scenario. So in this setting, the benzodiazepines are going to be the first choice. So that's the first choice drug. So that is to control the seizures first. So as far as the benzodiazepines are concerned, the preferred benzodiazepine is going to be lorazepam versus diazepam. Of course, we are going to prefer lorazepam as the first choice drug. Lorazepam, typically we use a dose of 4 milligram and you can give 2 doses. I mean, total of 2 doses. You can repeat once, which means first I can give 4 milligram IV, then it's IV benzodiazepine. So then I can give another 4 milligram. If possible, I can repeat. But as far as diazepam is concerned, I cannot repeat, and I'm not going to prefer diazepam, which is lesser effective compared to that of lorazepam. Suppose now seizure can be controlled, and you're going to give standard post-ictal care, or the seizure is uncontrolled. Seizure is uncontrolled with initial benzodiazepine means then you have to go for other alternative drugs. So you have to go for second line drugs in this setting. So what are the second line drugs that you can give? Second line drugs that you can prefer is phenytoin, or you can prefer fosphenytoin. Fosphenytoin is like phenytoin only, but lesser risk of thrombophlebitis compared to phenytoin. You can prefer fosphenytoin, or alternatively, you can prefer valproate or levetiracetam also. You have IV valproate, but you have to give a higher dose because of significant albumin binding of valproate, or you can give levetiracetam as well, which is also available IV very commonly. So remember, suppose if the patient is already on phenytoin, then you can use these drugs like valproate and levetiracetam. Suppose if the patient is not on phenytoin, not taking phenytoin, then you can probably use these drugs. But the general consensus currently is not to use phenytoin and fosphenytoin that commonly, because our idea is now moving up away from phenytoin. So in our usual routine practice, we don't really give phenytoin. I have not given phenytoin in the last 2-3 years, maybe even as oral or even as IV. My residents, if you ask, they don't know phenytoin. If you tell phenytoin to be loaded to them, they'll be looking like this. So phenytoin, what is the dose? Because they have not experienced at all. But nevertheless, in resource limited settings, you can use phenytoin as one of the main therapies. I mean, it again depends, but we prefer non-phenytoin based therapies. And suppose if still the seizure is continuing, after giving the second line drug, still seizure is continuing. So which means in the first 5 to 10 minutes, this is going to be the protocol. So as far as benzodiazepines are concerned, this is going to be in the first 5 to 10 minutes. This is going to be the strategy. And in the first 5 to 10 minutes, it's assessment and IV line. That's going to be the thing in the first 5 to 10 minutes. And in 10 to 20 minutes, your benzodiazepines are going to be the standard of the care. And the second line therapy and infusion should be tried in the 20 to 40 minutes period of status epilepticus. And once the seizure crosses 40 minutes, and which means your second line drugs also becomes ineffective, and if it's continuing, then it's better to induce a general anesthesia. Typically, we prefer IV general anesthesia in the setting, which means you have to intubate the patient first to give these drugs. And when you intubate, which means you are using a neuromuscular blocker like succinylcholine, or probably will be preferring vecuronium or rocuronium, but I generally use a non-depolarizing neuromuscular blocker because already the patient is contracting violently, throwing seizure. In that, if you are using a succinylcholine, there is a substantially higher risk of arrhythmia and your rhabdomyolysis. So that's why I generally avoid succinylcholine or any depolarizing neuromuscular blocker, but it's better to prefer a non-depolarizing neuromuscular blocker in this setting, which is better as a lesser risk of hyperkalemia and status epilepticus. And the problem with neuromuscular blocker is once you give a neuromuscular blocker, the muscle shaking will stop because you have blocked the neuromuscular junction. So any amount of stimulation now will not be able to produce any contraction on the muscle. So you might be falsely thinking that the seizure has disappeared because the shaking has gone. And that's because of neuromuscular blocker effect, but the brain is still throwing seizure. So that's why whenever you intubate and give a neuromuscular blocker, it's important that you do a continuous EEG monitoring, which means you should not get a false reassurance that the seizure has stopped. You have to always look for the continuous EEG monitoring. EEG in this setting is going to be the best example, best entity to know whether the seizure has stopped or not. So to stop the seizures, of course, I'll use an IV general anesthesia. IV drugs that I can prefer is midazolam, one of the important first choice drugs, or I can use propofol, but avoid propofol for using for more than 24 to 48 hours because it can result in something called a propofol infusion syndrome. We have studied anesthesia. It can cause carbulyuria, green colored urine, and hypotension, cardiac problems, cardiac arrest, arrhythmias. That is called as propofol infusion syndrome. If you're using a high dose propofol for more than 24 to 48 hours, the risk is always there. So try to avoid if possible, but if it's not possible, you can still go ahead with propofol, but be careful with the dose. And there is substantial definitions and guidelines are there on how to use propofol. And don't forget to intubate the patient, otherwise the patient will die, of course. And this is how you're going to manage a patient with the status epilepticus. Very, practical protocol based on the IV line and whether your benzodiazepines initially, then going to the second line drugs, then finally going to the third line drugs. As far as our other pictures are concerned, let me tell these three pictures. So you have three pictures which I have inserted here. So one is this, a classical example of something called a mesial temporal sclerosis. Mesial temporal sclerosis, very characteristic example. You can see that in the left, temporal lobe, in the medial side, you're having a sclerosis. These findings can be easily missed out in the CT. This is basically a T1 weighted MRI. You can see because the CSF is black. So it's basically a T1 weighted MRI. So where you can see this kind of a sclerotic appearance on the medial side of the temporal lobe. This is an example of a mesial temporal sclerosis. And then we have a focal cortical dysplasia. This is a congenital problem again. So which can result in refractory and recurrent seizures. And this is an example of a tumor. You know what this tumor is. This is a glioblastoma multiforme, which can happen in elderly people. So usually the characteristic feature of glioblastoma multiforme is this peripheral enhancement and with a central necrosis. And in CT, the central necrosis with peripheral enhancement is very classical of a glioblastoma multiforme. And at the same time, many students will believe that unless and until they see this kind of butterfly shape, they believe that it's not glioblastoma multiforme exam. Butterfly shape is only a typical description of glioblastoma multiforme, that it does not mean that it should be seen in all the patients. That is an example of a glioblastoma multiforme, so which can result in the development of seizures as well. And apart from that, we have some various seizure surgeries that can be done. But when will you do seizure surgeries? So remember, whenever you have 3 or more drugs, more than or equal to 3 drugs needed to control the seizures, it's like resistant hypertension definition. So if you need more than or equal to 3 drugs to control seizure, then you can consider, giving a surgery. Neurosurgeries can be tried. So for that, to understand it better, we have a risk ratio. So what is the risk of developing a recurrent seizure? Suppose a seizure that is newly diagnosed has almost 50% chance of becoming seizure free, even without treatment, has 50% chance of developing a recurrent seizure. So now let us assume the patient has got a recurrent seizure. Now you have started drug number 1. And after starting drug number 1, outcome will be the patient may become seizure free by around 15%. They become seizure free. And of course, around 40%, they become a recurrent seizure. So recurrent seizure may happen in 40%. Now let us assume you got a recurrent seizure. So you are starting a drug 2 in these patients. So once you start a drug 2 in these patients, now the patient may become seizure free in approximately 1%, and they can get a recurrent seizure in approximately 40% once again. And apart from that, now if you start a drug number 3, because the patient has got a recurrent seizure, if you start a drug number 3, now the chance of getting seizure freeness with 3 drugs is only 3%. The chance of getting recurrent seizures is approximately around 35%. Which means as you move from one drug to a higher drug, the chance of getting recurrency is actually quite high, which means the patient will not get less seizures if you add more drugs. The chance of getting seizure-free nature is actually quite less the more and more drugs you add, and the chance of getting recurrent seizures are also increasing the more and more drugs you add, which means the seizures are becoming more resistant. So that's the idea. That is the reason why whenever you are having more than 3 to 4 drugs are needed to control seizures, it is better to opt for certain kinds of neurosurgery. There are many neurosurgeries are available. I mean, neurosurgeries can make the seizure free by 50%, which means it's a little higher. 1 in 2 patients may get seizure free with neurosurgery. So that is why we are preferring a neurosurgery. And there are many different types of neurosurgery out there. Very common type of neurosurgery is the anterior temporal lobectomy that we do, where we remove amygdala. Remember, fortunately, all the problems will be on one side only. So if you remove from one side only, it's enough. So the memory will not be impaired that much if you remove only from one side. So amygdala, then probably you can remove a part of hippocampus on one side. So other side is still impact. So there will be no substantial memory problems. And you can remove anterior part of the temporal lobe also. Anterior temporal lobe. These are the areas that are generally considered to be epileptogenic, and removing these areas have the least post-operative effects on the cognitive function. So that's why we remove these areas, and the chance of the patient becoming seizure-free is approximately around 50%. And we have many new modalities like laser ablation is there. That's called a laser ablation causing amygdohippocampectomy. So you can remove amygdala, you can ablate the amygdala and hippocampus on one side using laser ablation techniques also. And many modern techniques are coming. Neurostimulators are there. So many modern techniques are also there as far as the seizure treatment is concerned. So neurosurgery you can prefer, and still it's an option. If the seizure is uncontrolled with 3 to 4 drugs, or if you need 3 to 4 drugs to control the seizure where you think the risk of recurrent seizure is very high, in that setting you can go for a neurosurgery for that matters. Fine. I think this must be enough as far as the seizure is concerned. Seizure-free percentage after second drug is 1%. That's all. After second drug is 1%. So recurrent seizure is 40%, and after drug 3 is around 3%. So these are the numbers that are given typically in the trials. All right. Rectal diazepam. You wonder what is after rectal diazepam? After rectal diazepam? No, this is only a temporary process. My God. So you're asking what is after rectal diazepam. This is only a temporary process. So which means once the seizure is controlled, you're going to achieve an IV line only. So idea is to control the seizures with rectal diazepam. You want to put an arrow like that, you can put. So idea after rectal diazepam is once the seizure is controlled, you have to achieve an IV line and you have to treat subsequently. So it means after rectal diazepam, what you'll do? You will give more and more rectal diazepam. I don't know, that's understandable. I don't know why you're asking that question. That's a real difficulty in teaching kids most of the times, asking these kind of questions. Okay. Do you understand? So that we can move to the next topic before lunch. Yes, I think again it's a power pack session, and you got to know all the information with regards to seizure and status epilepticus. A single hour of discussion, I think we had discussed 1.5 hours, and that's worth. And almost 95 to 99% of the questions, whatever is asked in epilepsy or seizure, you can answer based on this itself. I don't think you need anything else to really know. This much only they will ask most of the times. You can try attempting questions. Once you start attempting questions, only you'll be able to understand whether you're able to answer them or not. That's very important again. Okay. So our final disease that we need to discuss is on the Parkinsonism. So because that's really important as well. That's the last one I'm going to discuss anyways, nevertheless. Parkinson disease. And we need to know the circuit of the basal ganglia in a very simple way. So to understand this circuit, let us start with the basal ganglia anatomy first. I'm not going to discuss on the details of anatomy because my idea is to only discuss in a very logical way. So once it makes some sense and logic, that's enough. Most of the times we are not going to become neuroanatomists, by the way. So just understand what's happening over there and just move on. No need to keep on pestering on, like this circuit, that circuit. But I can explain. It's not a big deal to explain because everything has been delineated quite clearly. But we don't really want that. I'll tell you most important points, and when it makes logic and sense, let us move apart. And the first one is the basal ganglia and the subthalamic nucleus circuit. We know the basal ganglia is divided into two based on our basic understanding. One is called the neostriatum. So that is NS. Neostriatum means caudate and putamen together. We call it as neostriatum. Remember, if you take the original anatomy of basal ganglia, so you will be seeing something like this, where in between you have this internal capsule fibers. In between you have this internal capsule fibers like this, and you would have studied this is caudate and this is putamen, and this is the globus pallidus, which is further divided into globus pallidus internum and globus pallidus externum. You would have studied all this in your basic anatomy. And this is axial section, and this is how it looks, and you will see thalamus over here somewhere. So I don't want to draw that. But nevertheless, like this caudate and putamen are evolutionarily linked with each other, which means if you take the basic evolutionary paths, caudate and putamen are basically together. They are like husband and wife. They have always been together in the evolution. And unless and until we evolved into higher structures and the cortex become bigger and the corticospinal tract become prominent, and they separated this husband and wife, like from each other. So even though they are separated physically, like most of husband and wife, they are connected emotionally, and that is why still they are considered together because they form the same function. And together we are going to call caudate and putamen, even though they're anatomically separated, physiologically they are same, and that's why we call by a common name called as neostriatum. But remember, there will be another structure you would have studied in your anatomy, that is this putamen and globus pallidus together. This is called as corpus striatum. That's a different terminology. That's an anatomical terminology. That's corpus striatum, and you have the caudate here. That's different. But nevertheless, the neostriatum is what is physiologically important because that includes caudate and putamen together, which are functionally together, basically. And you have a globus pallidus separately. The most important part, fact to know is whatever may be the output, whether it is a direct pathway, which I'll be discussing in some time, or whether it's an indirect pathway, which I'll be discussing in some time, whatever may be the fact, your output from the basal ganglia will be coming from the globus pallidus, And you can remember by a mnemonic, G stands for G, which means globus pallidus. Whatever may be the output that is coming from the basal ganglia, it's going to be GABAergic. It's a GABAergic pathway. So whether it's direct or indirect, whatever output that comes from the basal ganglia will be coming from globus pallidus. And that output from the basal ganglia that is coming from the globus pallidus is going to be GABAergic pathways only. It's a GABAergic neurons. And of course, as far as the direct pathway is concerned, you can go to the thalamus first. As far as the indirect pathway is concerned, you'll be moving on to the subthalamic nucleus first, and then you will be reaching the thalamus. So when you directly reach the thalamus, this pathway is what we refer to as a direct pathway. And if you reach the thalamus indirectly through the subthalamic nucleus, this is what we refer to as a indirect pathway. And all these are GABAergic neurons. And if you ask any neuron apart from this in this pathway will be glutaminergic pathway. Let us discuss about that. For example, subthalamic nucleus to thalamus, it's a glutaminergic pathway. It's a glutamate producing neurons. Glutamate pathway. Clear? So what is the idea of the basal ganglia? As I told you, if you see the memory, when you take the memory circuit, which I've drawn some time back, especially for procedural memory or for doing some complex executional tasks, you need basal ganglia's like help, because basal ganglia is the one, for example, that stores the programs for how a movement should be made. So they have that programs. So in fact, they fine tune those programs. It's present in the cortex as well as basal ganglia, but basal ganglia's help is needed to fine tune those programs and give a correct program for a correct kind of activity. So that is why whenever you want to do a movement, for example, let us assume this is a motor cortex, and many association areas are also there which can communicate with the basal ganglia. So which means whenever they want to perform an activity, whenever they want to perform a particular movement, they need to consult with the basal ganglia about the appropriateness and the rightness of the particular activity and movement. So remember, the input that comes into the basal ganglia means it's always through the neostriatum. The output that comes out of the basal ganglia is always from the globus pallidus, and the input that's going to come into the basal ganglia is always through neostriatum. So this neuron, these neurons will be called as something called, this coming from the cortex. So of course it will be a corticostriate neurons. So I can write this is a corticostriate pathway. So of course, I told you anything else apart from this basal ganglia output will be glutamate producing. So these are glutamate producing neurons. And this is subthalamic pathway. And this again will be glutamate producing. And you have pallidothalamic neurons, they'll be GABAergic, and you have pallido-subthalamic neurons, this pathway, pallido-subthalamic neurons, again they'll be GABAergic. And this thalamus, now, thalamus of course like a relay center to the cortex, in the sense like without the thalamic permission, nothing can reach the cortex. It's like a gatekeeper to the cortex. So like how AV node is for the ventricles, like thalamus is like a gatekeeper. The cortex, anything that goes into the cortex has to go through the thalamus only. So thalamus now relays this information to the cortex, and these are called as thalamocortical neurons. We know that. And of course, they are going to produce glutamate only. So now the circuit has to be clear. You have a direct pathway, you have an indirect pathway, and you also know that the cortex consults with the basal ganglia and gets information through the thalamus to perform a motor activity. As simple as that. This is what is happening in a very simple way, even though this is extremely oversimplified, and the basal ganglia does not only work by this principle. Of course, it's not like a computer circuit, but still this makes a lot of sense. So you have corticostriate neurons, thalamocortical neurons, subthalamothalamic neurons, which are basically glutamate, and we have globus pallidus, that is pallidothalamic and pallidosubthalamic neurons that are going to produce GABA. Simple principle. Anything that comes out of the basal ganglia, it will be GABAergic. Anything apart from this in this particular circuit will be glutamate producing neurons. Clear? So that's all. Fine. So we know the neurotransmitters as well. Then the effects of the basal ganglia can be modulated by a variety of neurotransmitters. One of the important neurotransmitters is dopamine for that purpose. Let us draw the basal ganglia here. It's a substantia nigra here. And where is substantia nigra? It is basically present in the midbrain. Substantia nigra is basically present in the midbrain. In the midbrain, you have tectum and tegmentum. In the anterior part of the midbrain, you have some blackish discoloration. of one structure. This is what we refer to as substantia nigra. Remember, don't confuse this with subthalamic nucleus. So it's a substantia nigra I'm going to write by SN. And these contain dopaminergic neurons, which means they produce dopamine. And from the substantia nigra, one of the most important pathway that connects with the basal ganglia and that causes input into the basal ganglia through the neostriatum. Of course, input to the basal ganglia means it should enter the neostriatum only. So this pathway, we know it's what we refer to as the famous nigrostrial pathway, because you know it's a substantia nigra and it's going to enter the neostriatum, so it will be called as nigrostrial pathway. And of course, you know what is the neurotransmitter that will be producing, that is dopamine. For that, I mean, you know, like you can ask, like, what about direct and indirect pathway? Usually for direct pathway, it is D1 receptors. That's very important. So I can write here, maybe not here. So for the direct pathway, dopamine, this dopamine is to activate the direct pathway, and that happens through so I can write direct pathway here. Says dopamine effect on the direct pathway will be more often through the D1 receptors. That's basically a kind of stimulating the direct pathway, and effect on the indirect pathway will be mediated through D2 receptors, and it's basically like inhibitory kind of a pathway. So they're going to inhibit the indirect pathway and they're going to activate the direct pathway as far as current understanding is concerned. And more importantly, now what is the basic function of the direct pathway on the motor cortex? On the motor cortex, the effect of the direct pathway is to stimulate a motor activity, and the effect of indirect pathway is to inhibit the motor activity. I mean, since I'm not telling in the crude sense, even though it looks like that, but it's increasing or reducing the motor cortex activity. So they increase the motor outcome if the direct pathway is stimulated. If the indirect pathway is stimulated, you are going to inhibit the motor outcome from the cortex. So it's like, you can understand, like a fine tuning of a thing. So you need to have a balance between stimulatory and inhibitory pathways. Now what dopamine does is, dopamine stimulates the direct pathway, and we know it inhibits the indirect pathway through D1 and D2 receptors, and we know that. So the net effect of dopamine, so final net effect of dopamine on the cortex, if you take, so they stimulate the direct pathway and they inhibit the indirect pathway, which means the net effect of dopamine on the cortex is to bring out a motor activity. They're going to cause some motor activity or increase the motor activity from the motor cortex. So that's what dopamine is going to produce, because they're going to stimulate the direct pathway and they're going to inhibit the indirect pathway. That's what is going to happen. And remember, you have a lot of other areas where dopaminergic neurons project, but nigrostrial pathway is for basal ganglia only. But you have a lot of other areas. For example, I can write a ventral tegmental area, as called a VTA area, that's coming from the midbrain only. This is also a region which contains dopamine producing neurons. So the first place where these neurons are going to project is towards the cortex, number one. So these are also dopaminergic neurons, which can project into the cortex. This is, I mean, whenever you call midbrain, there is another name for the midbrain called as mesencephalon. You will have prosencephalon, mesencephalon, rhombencephalon. Prosencephalon is forebrain. The majority of the cortical structures and all these things will be originating from the prosencephalon. Mesencephalon is the midbrain, and rhombencephalon is the hindbrain. We know that medulla, pons, and your cerebellar structures come from the rhombencephalon. That is the hindbrain. Mesencephalon is the midbrain, basically. And prosencephalon, is the one that's going to produce the cortical structures, and that's the one that's going to produce the diencephalon. That is the thalamus and related structures, all the thalami related structures, including the optic nerves, coming from the diencephalon. But mesencephalon means midbrain. Why I told you that? Because this pathway, this dopaminergic pathway that's coming from the ventral tegmental area, is what we refer to as something called a mesocortical pathway. Mesocortical pathway, because it's coming from the mesencephalon. That's why it's called a mesocortical pathway. This mesocortical pathway is very, very important for planning, calculation, planning, judgment, calculation. So many other events are there, and the dopamine is really important in this setting. And at the same time, there is another dopaminergic pathway that's coming from the ventral tegmental area. So I can write like this, which can project into the limbic system. This is called a mesolimbic pathway. You know the limbic system structures, especially that amygdala, hippocampus, entorhinal cortex. This contributes to the limbic system, and this, of course, must be a mesolimbic pathway, and where dopamine again projects into the mesolimbic system as well. Dopaminergic system again projects into the limbic system. So where this is very, very important for emotional modulation. Like, for example, dopamine to the limbic system will result in addiction, pleasure, and euphoria. That's what is going to get generated as far as the mesolimbic system is concerned. So why this is important? Let us see. Because there are a lot of drugs which act on the dopaminergic pathway and can have a lot of side effects. But apart from this, the final dopaminergic pathway that I have not described. So there are many dopaminergic pathways. The most important dopaminergic pathway is going to be the nigrostrial pathway. So this is one dopaminergic pathway. So I can write, I can shade this is one dopaminergic pathway. We have another dopaminergic pathway here, and we have another dopaminergic pathway. Apart from this, we have another dopaminergic pathway that is basically coming from the pituitary, from the hypothalamus. We have not drawn that, so I can probably draw maybe here. It's not a right place anatomically, but if you want, I can draw here, no problem. So the pituitary is actually controlled by the hypothalamus. So you have a hypothalamus, and basically pituitary is controlled by the hypothalamus through one important pathway that affects the lactotrophs. Just hold on, my pencil is not getting connected. Yes, got it. I have a spare one always, that's why. Okay, so we have a dopamine here. So that is coming from the hypothalamus, especially from the arcuate nucleus. There's an area in the hypothalamus called arcuate nucleus. And can anyone name this pathway that is controlling the lactotrophs? Anyone knows this pathway? Yes, correct. That's a tubuloinfundibular pathway. Tubuloinfundibular pathway that is coming from the hypothalamus, arcuate nucleus, that controls the lactotrophs that secrete prolactin, which is where they inhibit them. So there are 4 basic pathways. So now coming back to the pathways of dopamine in the brain, there are 4 pathways. One is the nigrostrial, of course, that's very important. Then we have mesocortical, mesolimbic, and tubuloinfundibular pathway for the control of prolactin release from the hypothalamus. But anyways, what is important for us is only one thing. That direct pathway is going to stimulate the cortex to produce a motor activity. Indirect pathway is going to inhibit the motor activity, and dopamine is going to stimulate the motor activity. This is the final take-home point. Apart from the dopamine is also important in producing this kind of pleasureful experiences like addiction, euphoria, and other kind of cortical functions like planning, calculation. For all these things, dopamine really helps a lot. And they can also result in inhibition of prolactin release from the pituitary through D2 receptors that is present in the lactotrophs, and they're going to reduce the prolactin release. So this is going to be the entire nutshell. And remember, as far as the neurotransmitters are concerned, anything that comes out of the basal ganglia is going to be GABAergic. Anything apart from that is going to be glutamate producing neurons, except the nigrostrial pathway that is going to produce dopamine, for that matters. And next thing, what we can think about is what are the effects of different drugs that we see. For example, if I give anti-dopaminergic drug, like for example, let us assume a drug that produces anti-dopaminergic, like haloperidol. So what will be the effects of haloperidol? Number one, why I give haloperidol? Because it's a typical D2 blocker. But why I give haloperidol is because I wanted to affect this limbic system, and I wanted to reduce the addiction and euphoria, which means it's important for treating schizophrenia. So number one. But even in schizophrenia, which will be affected. So that hallucinations, euphoria, that kind of positive symptoms can be treated very well with haloperidol because that's based on dopamine. But many schizophrenic patients will have negative symptoms like anhedonia. You would have started, I don't know whether you are a final year or a pre-final year, I don't know. Schizophrenia is basically going to have two types of symptoms, but I cannot describe everything right now. So you have positive symptoms and negative symptoms. Positive symptoms are that hallucinations, euphoria, that kind of new things that come. These are positive symptoms, and they have negative symptoms, anhedonia, loss of pleasure in previously pleasurable activities. And these kind of negative symptoms can actually get worse with treatment with haloperidol because they can reduce the euphoria, which means they can cause more and more anhedonia. So they can reduce hallucinations as well, but they can reduce more and more. They can produce more and more anhedonia. So which means the positive symptoms can be treated, but negative symptoms are basically worse in the event of schizophrenia. So nevertheless, they're going to block the dopaminergic pathway in the basal ganglia also. We know that dopamine is important for, producing motor activity or increasing the motor activity. So one of the important side effects of any dopamine blocking drug, especially drugs like haloperidol, antipsychotics, are going to be Parkinson features, Parkinsonism. So why Parkinsonism? Because they're going to reduce the motor activity, which means they're going to produce bradykinesia and rigidity. So why in Parkinsonism you have a problem? Because in Parkinsonism you have this degeneration of nigrostrial pathway. If you have degeneration of nigrostrial pathway in Parkinsonism, of course, you're going to result in the classic problems like bradykinesia and rigidity. So, I mean, of course, whenever you don't have dopamine, you have reduced motor activity. When you have a reduced motor activity, you're going to result in bradykinesia. Bradykinesia is kind of a hypokinetic movement disorder. So whenever you have degeneration of this nigrostrial pathway, you'll have reduced movements, which will result in Parkinson disease, which is basically a hypokinetic movement disorder. Hypokinetic movement disorder. That is Parkinsonism, hypokinetic movement disorder. Okay, hypokinetic movement disorder. That's, an example for hypokinetic movement disorder is Parkinson disease. And similarly, this kind of Parkinson features can be produced with haloperidol also. That's why one of the important side effects of haloperidol is drug-induced Parkinsonism. And at the same time, please understand haloperidol can actually make the negative symptoms of schizophrenia worse, or any antipsychotic for that matter, especially the typical antipsychotics that work on the dopamine receptors. And what could be the other side effects? Even the cortical abilities can be reduced to a great extent, like calculation, planning and all. That's one problem with these antipsychotic drugs as well. And at the same time, this haloperidol used, apart from schizophrenia, there are other uses of haloperidol. Like for example, we know that haloperidol is going to reduce the motor activity, which means when they block the dopamine action, you're going to reduce the motor activity. Once they reduce motor activity, they can be helpful in hyperkinetic movement disorders. Other uses, hyperkinetic movement disorders. What are the best examples for hyperkinetic movement disorders where haloperidol can be helpful? One is, of course, the chorea, where you have a disorder called Huntington's chorea, where haloperidol is a very important treatment, where it can treat both psychosis in Huntington's chorea as well as the extrapyramidal movements that are happening in Huntington's chorea. Or you can use in other movement disorders like Balismus, even though that's not the real drug of choice, but Balismus is there. Then we have athetosis. For all these things, you can treat haloperidol. Even for Sydenham's chorea, if they ask you, haloperidol is one of the very important lines of treatment to reduce the motor activity, because haloperidol is something that can reduce the motor activity by blocking the dopamine action in the basal ganglia. And now that comes to a question. So if Parkinson disease is producing a hypokinetic movement disorder, what a basal ganglia problem will produce? Remember, basal ganglia, leave of all those things. The main output that is coming from the basal ganglia is basically GABAergic output only. Whatever may be the fact, whenever you have a basal ganglia problem, you're going to result in a hyperkinetic movement disorder, which means you're going to result in loss of this inhibitory neurotransmitter. Logically speaking, even though I don't want to really speak of all the connections that's happening in between, whenever I have a basal ganglia issue, I will lose GABAergic projection into the thalamus or the subthalamic nucleus, and ultimately I'm going to result in some hyperkinetic movement disorder. So whenever you talk about a basal ganglia disorder, you're going to result in hyperkinetic movement disorder. For example, if you have a caudate and putamen involvement, or any caudate or putamen involvement, or neostriatal involvement, you can tell together also, you're going to result in a hyperkinetic movement disorder called chorea, basically. Or whenever you're going to have a globus pallidus involvement, you're going to result in a hyperkinetic movement disorder called acidosis classically. And whenever you have a subthalamic nucleus involvement, and once again, you can understand like subthalamic nucleus is like an indirect pathway, and the main function of indirect pathway is to inhibit the motor activity. We know that. So because subthalamic nucleus is something that is concerned with inhibition of motor activity, and it's a very integral component of the indirect pathway, we can assume that whenever you have a problem of the subthalamic nucleus, you will result in something called a hyperkinetic movement disorder, referred to as balismus or hemibalismus, which means all these are basically hyperkinetic movement disorders. They are not hypokinetic movement disorders. For information, they are basically hyperkinetic movement disorders. And Parkinson disease, on the other hand, is basically a hypokinetic movement disorder. And because Parkinson produces bradykinesia rigidity, it's also called as akinetic rigid syndrome, where the patient will have akinesia, that is bradykinesia, with rigidity, that's called as akinetic rigid syndrome. In exam, whenever they ask about akinetic rigid syndrome, they indirectly mean that you're talking about Parkinson disease or some form of Parkinsonism. That's what you're dealing with. On the other hand, you can understand something called a levodopa. So, or any dopamine receptor agonist. So what they're going to do is they're going to increase the flux of dopamine into the brain. They're going to be exactly opposite. This levodopa can be useful in Parkinsonism. Of course, especially idiopathic Parkinson disease, they'll be highly levodopa responsive. This is one of the use of levodopa. But you can understand the side effects of levodopa as well. So we know whenever you increase the dopamine concentration in the brain, you're going to increase the motor activity. So once you increase the motor activity, one of the most common side effects of levodopa is going to be dyskinesias, which means increased motor movement, and unwanted motor movements can happen in the setting of a levodopa. And at the same time, second important side effect of levodopa and dopamine receptor agonists that you can understand from this is, because dopamine is implicated in psychosis and they're implicated in this addiction, euphoria, and all this stuff, they can result in psychosis. That's the second important side effect of levodopa and dopamine receptor agonists. So based on understanding these pathways, it's very easy to get all these things. And at the same time, whenever you give a dopamine receptor agonist, a form of psychosis happens. That's called a compulsive gambling. That's a very important question in exams as well. Why this happens? Again, because of the effect on the limbic system. This is a psychiatric effect on the limbic system that happens because of levodopa use, to be precise, or dopamine receptor agonist use, to be precise. Just hold on. I'll be starting in a while because I have some fluctuations here. In 2 minutes, I'll start.